Hello everyone. Um, can we hear me? Please, I hope you can all hear me. Can we hear me? Hello?
Yes, sir.
Okay. Um, I'm good everyone. Today we are going to be starting the multi-system discussion, and um, we are going to start by talking about shock. So we all know what shock is. This is just a condition where we have impaired tissue level oxygenation, you know, due to different pathologies. And in the process, there's going to be dysfunction within um, the organ level. Like there's going to be organ level dysfunction because of impaired oxygenation at the tissues. So there are different causes of shock, different types of shock. So broadly classified into four types. We have the hypovolemic, the cardiogenic, the obstructive, and the distributive shock. So under the distributive shock, we have majorly septic shock, anaphylactic shock, and neurogenic shock. So we have so many parameters we evaluate to also separate the different causes of the shock. So we look at the cardiac output, we look at the pulmonary capillary wedge pressure, which gives us an estimate of the pressure within the left side of the heart. We also look at the central venous pressure, which gives us an estimate of the pressure within the right side of the heart. And we also consider the peripheral vascular resistance. So there are so many changes that happen to these parameters in the different types of the shock. So we have a table here that we extracted from um, the the first aid, and it talks about the different classes of the shock and what changes in this parameter do we expect. So the first is hypovolemic. And just from the word hypovolemia, it means that we don't have adequate circulating blood volume, either due to hemorrhage, dehydration, burn, injury, anything that is getting fluid out of the body can cause hypovolemic shock. So the mechanism is essentially about volume depletion. And because of the volume depletion, we expect all the pressures in the body to drop because if there's no volume, there's nothing to move blood through the heart and the other body parts. So essentially all the pressures in the heart, they are going to drop. So you expect a drop in the central venous pressure. You expect a drop in the pulmonary capillary wedge pressure, which is talking about the left side. There's going to be a drop in the cardiac output because there's no blood volume to be pumped out. Cardiac output is a product of stroke volume and the heart rate. So if there's no volume, no blood volume, there's going to be like a reduction in the stroke volume. And of course, there's going to be a drop in the cardiac output. But in response to this drop in the cardiac output, in order to maintain blood pressure, the systemic vascular resistance is going to increase. So this is just more like a sympathetic reflex that is set in place to respond to hypovolemic shock. So the way the body is going to try to maintain perfusion to the tissues is to find a way to maintain the blood pressure. So if there's going to be a drop in the cardiac output, the way to kind of achieve a normalcy in the blood pressure is to increase the systemic vascular resistance. And this is mediated by the sympathetic drive that is increased. So it means that in any pathology where the sympathetic drive is affected, for example, somebody with neurogenic shock from CNS injury, you don't expect an increase in the sympathetic response, and you don't expect an increase in the systemic vascular resistance. Very, very important. So, and of course, the mixed oxygen content, in the venous blood is going to be reduced. So, because of the a drop in the cardiac output. So, anything that drops cardiac output, definitely SVO22 will reduce. So, that's just a quick way to remember it. So, moving on to cardiogenic shock. In cardiogenic shock, the problem is not essentially about volume depletion from the body. It is just an inherent problem with the heart. and there's an impairment in the ability of the heart to contract to get blood out of the heart into the tissues. That's just what is happening. So either the person has suffered a myocardial infarction that impairs the contractility of the heart, or the person had heart failure, maybe from dilated cardiomyopathy, or the person has valvular dysfunction, maybe the person has mitral regurgitation, or the person had an arrhythmia. All these things is going to affect the contractility of the heart, so there's going to be left heart dysfunction. And what is going to happen is, because there is impairment in the contractility of the heart, there's going to be volume pulling in the heart. And this volume is going to be transmitting a backward pressure, to the left atrium and to the right atrium. So if there's a lot of blood in the left ventricle, a lot of blood in the right ventricle, the right ventricle cannot pump blood out into the pulmonary circulation. So blood is going back to the right atrium, causing an elevation in the CBP. Blood in the left ventricle is pulling in the left ventricle, transmitting back to the left atrium, back, to the pulmonary vein, causing an elevation of the pulmonary capillary wedge pressure. And because of the fact that they cannot get the blood, the left ventricle cannot get the blood to the aorta, cardiac output is going to drop. And of course, there's going to be a sympathetic response, to try to, maintain blood pressure, causing a raise in the SVR. And because of the drop in the cardiac output, the SVO2 is going to drop. That's cardiogenic. So just look at the pressure in the right and the side. Is it elevated? Once both of them is elevated, and you look at the clinical scenario being described, it's something relating to the heart, just go and pick cardiogenic shock. Obstructive shock. So here, it's not as if there's a problem with the contractility of the heart. No, there's just some form of obstruction somewhere, maybe within the vessel, or the heart in itself is kind of compressed, making it difficult to get blood out of the heart into the tissues. So somebody with a cardiac tamponade, the heart is compressed. Somebody with tension pneumothorax, there's a lot of tension within the lungs. And because of the fact that the heart is sandwiched between the lungs, it can be compressed in the process too. Or maybe somebody has a pulmonary embolism, so creating an increased afterload for the right ventricle. So that means that there's an increased resistance that is going to be encountered by the right ventricle to get blood into the pulmonary circulation. Because if there's pulmonary embolism, there's a clot sitting within the pulmonary artery. So not allowing blood to move from the right ventricle to the pulmonary artery. That's a form of obstructive shock. So the person is going to be having a drop, an increase rather, because majority of the problem in obstructive shock are confined to the right side. So there's going to be an increase in the central venous pressure. But the only one that would, increase the pressure in the left side is cardiac tamponade. So, and I will explain. We are not wasting too much time. So let me just put it here. We have the heart like this. This is, let me say that this is a pericardium here. This is a pericardium, and this is a heart within the pericardium. So this is a pericardium, like this, surrounding the heart. And what we have here is like the pericardial. Let me say this is a pericardial space. Sorry, let me draw down what is neat. So this is a pericardial sac. This is a heart. So in cardiac tamponade, there's kind of, maybe there's a pleural pericardial effusion, and you have a lot of fluid build up from this part. There's pericardial effusion. So a lot of fluid is here, like this. And the fluid starts getting bigger, larger, and they start compressing on the heart. Now, it will get to a point where you have equalization, or maybe let's use the word equilibrium, in which all the pressures within that chamber is going to be equally distributed through all the chambers of the heart. So number one, because if fluid is accumulating in this space, compressing on the heart is going to find it very difficult to relax. That's number one. So there's going to be an increase in diastolic pressure. They'll find it very difficult to relax because they are being compressed. They cannot relax anymore. So they're going to have a serious problem with diastole. And now, because of the fact that where the fluid is accumulating is within the pericardiac sac, and since all the chamber of the heart are surrounded by the pericardiac sac. So that means that no chamber is going to be spared. So the right atrium, the right ventricle, the left atrium, and the left ventricle, that diastolic pressure that is increased is going to be transmitted to all of them, and it's going to be the same. So that is why we have an elevation of both. Let me go back to that of both uh, an elevation of both the central venous pressure and the pulmonary capillary wedge pressure in a patient with cardiac tamponade. But whereas in somebody with tension pneumothorax, because tension pneumothorax, a lot of pressure being transmitted in the lungs, and that one is going to be transmitted to the pulmonary vessels, which is going to create maybe an increased pressure for the right ventricle to work against. So that's only going to elevate the CVP. Same thing with PE. PE is just an obstruction at the level of the pulmonary artery. So the right ventricle is going to find it difficult to pump blood out of the right ventricle to the pulmonary area. So blood is going to be moving backward to the right atrium to the central venous area, so causing a rise in the CVP alone. But it is only cardiac tamponade that is going to increase both CVP and PCWP. Very important. And of course, all of them will cause a drop in the cardiac output. There's going to be a reflex increase in the SVR, and of course, SVO2 is going to drop. So ignore this. SVO2 drops in all of them. Now, distributive shock. The common pathophysiology of distributive shock is systemic vasodilation. If they ask you, what is distributive shock? Anything that can cause vasodilation. Could be from different things. Now, two major things might be responsible for vasodilation. Either we have a lot of cytokines in circulation from mast cell degranulation. We have a lot of histamine being released. So maybe from sepsis or from anaphylaxis, there's going to be histamine being released, and histamine is going to cause the systemic vasodilation. There could be CNS injury. So if somebody is having CNS injury and the person is having distributive shock, so that doesn't occur from release of cytokines. No, that just happened because you have taken out the sympathetic supply. So this person had a spinal cord injury and there's transection of the sympathetic tract. If you remember the anatomy of the central nervous, the spinal cord, remember at the lateral part we have the sympathetic fibers, the intermediolateral part. That's where we have the sympathetic fibers running through. So if there's any transection of those sympathetic fibers, there's nothing to cause vasoconstriction of the vessels. So the tone of the vessels is automatically lost. So the person is going to be having vasodilation. And one thing that happens usually when there's vasodilation, there's usually going to be an increase in the stroke volume, because it will be very, very easy for the heart to pump blood into the vessels, because if the vessels are vasodilated, they are much more open to receive blood. So if you are starting with sepsis and anaphylaxis, because of the fact that there is vasodilation, there's going to be an increase in the cardiac output. But the pressure is going to drop because the blood is going to be moving slowly because there's vasodilation everywhere. So even the venous return to the heart is going to reduce. So let me explain something quickly. So if we have vasodilation of the vessels, typically, let's say that these are the veins, because about 60% of the blood volume are accumulated in the veins. True or false? Anybody agrees? 60% of the blood volume at a particular time occur or lies within the vein. Do we agree or we don't agree? Do we agree?
Yes.
So majority of the blood occupies the vein. Now, when there's vasodilation, it is very, very difficult for us to achieve venous return because there's going to be increased capacitance in the vein. They are going to start accumulating those blood. That's capacitance. They have capacity to hold the blood. The only way you can get the blood back to the heart is to squeeze it. So that's why they say wear test stocking, so that you can squeeze it, generate an increased pressure, vasoconstrict those vessels so that you can increase venous return back to the heart. So it means that if I have a pathology that is causing venodilation, there's going to be a lot of blood pooling within these vessels, and there's going to be reduction in the blood flow back to the heart. So it means that in somebody with septic shock, there's going to be a drop of both the PCWP and the CVP, but cardiac output is going to be increased. Now, what is going to happen to MVO2? Don't forget, we have said that cardiac output increase. And again, in septic shock, because of metabolism that is kind of impaired by the tissues, because it is a microorganism that is taking over everything. So metabolism at the tissue level is kind of dropped. So they are not even taking a lot of oxygen for their own metabolism. So the SVO2 in septic shock increases. So septic shock and anaphylactic shock, they have the same parameter changes. They have the same pathophysiology. It is due to the vasodilation from the cytokines, released from whatever is the trigger of the cytokines. So there's reduced metabolism in both of them. And that is the reason why SVO2 is increased. The vasodilators, they are the ones causing the drop in the SVR. Because of the drop in the SVR, there's increased cardiac output, and because of the fact that there's reduced venous tone, reduced venous return, CVP and PCWP is going to drop. But what happens in CNS injury? Fine. Somebody has CNS injury. There's a transection of the sympathetic component. There's going to be vasodilation, right? So SVR automatically will drop. Fine. SVR drops. But what's going to happen to cardiac output? Cardiac output should increase now, just like we have said in some of our septic shock. And I'm like, no, cardiac output is not going to increase. In fact, this is not a cause of high cardiac output failure. And the reason is because if you look at the equation that talks about the cardiac output, so we said that the cardiac output is what? CO equals stroke volume times heart rate. What do we think will happen to heart rate in somebody that has what's it called? CNS injury. Anybody knows what happens to the heart rate? Anybody knows what happens to the heart rate? Eh?
It reduces.
It
Reduce.
reduces. So that is the reason why the cardiac output drops in there. So if you see somebody that is having shock, hypotension without a reflex tachycardia, you think about neurogenic injury first. It is only neurogenic injury that you don't have that reflex increase in the heart rate or, SVR in somebody with shock. So that should tilt your mind towards neurogenic injury. Quickly, you check the pulse. The pulse is somebody's having shock and the pulse is 50. You know your diagnosis until otherwise proven is going to be a neurogenic injury. Now, what are the other parameter changes that we expect in neurogenic injury? So let's go back to that our picture. So if we look at the PCWP, it drops because of what? There's going to be what? Vasodilation. So there's going to be pooling of blood in the veins. So PCWP drops, CVP drops. But don't forget the skin. The skin is going to be warm and dry. So it's usually warm and dry in people with distributive shock. It is warm and dry in them, especially people with, septic shock and anaphylactic shock because of the increased cardiac output. So in a way, there's kind of increased perfusion to the tissues. There's increased perfusion, yes, but the tissues are not actually using the oxygen for their own metabolism. So that is why the definition is actually impaired tissue oxygenation. That is it. So the inflammatory process is using the oxygen, converting it to free radicals, or the microorganisms are using the oxygen for their own growth. The tissues don't have oxygen for its own, own metabolism. So that is the summary of what we have in this table. So, so now, so let's go back to what we do in each of them. So if somebody has hypovolemic shock from trauma, from burn injury, from excessive dehydration, what you want to do is to replace with isotonic fluid. You want to give Ringer's lactate or normal saline, anyone that you have. Ringer's lactate is much more physiological, than normal saline. So you give that. If you have given 2 liters of normal saline or Ringer's lactate and you are not seeing any improvement, that is an indication to go and give blood. They put it in the option. Continue giving ringas lactate. Continue giving. You're not going to pick that. So once you have given like 2 liters, no improvement, immediately go and give blood, provided that the person is having hemorrhage. So for cardiogenic, you just want to treat the underlying cause. MI, and do a PCI, schedule for CABG if there's a need. You know, if it's mitral regurgitation, just give a vasodilator. If it's chronic, for the chronic one, give a vasodilator so that you can reduce the afterload, and encourage forward flow. I know that Dr. Babarinde will have talked about that in cardiology. So if it's a VSD, go and repair the VSD. Arrhythmia, give antiarrhythmics. There's a need to cardiovert, do your cardioversion. If there's a need to defibrillate the patient. Identify the underlying cause and treat immediately. Sometimes people with heart failure, they might need some extra structural support. You might want to place an intra-aortic balloon pump so that you can have that contractile effort, that inotropic action to get blood out of the heart into the tissues. You might need to give inotropic agents too, like digoxin, dobutamine and all those things to encourage, you know, um, pumping blood into the vessels. Then for obstructive, you just want to treat the underlying cause, cardiac tamponade and pericardiocentesis, tension pneumothorax, need do it. Massive PE, go and do your what? So massive PE, what are we going to do for this patient now? Massive PE with obstructive shock, what are we doing? Anybody? We what? Our rescue, my people. We thrombolyze.
Thrombolytic.
So do a pericardiocentesis, decompress that pneumothorax by putting a needle. Don't forget, large pneumothorax, we put in a chest tube. Tension pneumothorax, we put in a needle. So massive pulmonary embolism, you just go and thrombolyze. And don't forget equalization of the pressures in cardiac tamponade. You can even see it is even here. Thank God they have it here. There's equalization of all the. So once you see your questions 10 and they are listing the pressures in the right atrium, right ventricle, left atrium, your own assignment is just to quickly look at the diastolic pressure of everything. Is it common? Once you see that the diastolic pressure in everything is uniform, your answer is cardiac tamponade until otherwise proven. Some people will be confused in the exam that, they just listed 8 pressure. I don't even know what to think. That is just what you need. That's just what they want to pick out. Just look at the diastolic pressure. Is it the same? This guy is having equalization of all the pressures, and is most likely having cardiac tamponade. And they will even now make it confusing. What they will now be asking is, what is your best next step? In fact, you don't even know what is going on. They're already asking you, what are you going to do next? They're not even asking that, what's your diagnosis? It's going to be, what's your best next step? So your own assignment is to look at the pressure, make your diagnosis, and you choose your pericardiocentesis as your best next step. So, distributive shock, sepsis, a lot of organisms, they are there. Just give your IV fluid. Giving your what? Your IV fluid. That's the number one thing to do in sepsis. If you go and pick antibiotics, you are your own. The number one thing to do is to give IV fluid. After IV fluid, consider blood spectrum antibiotic because you need to take that person out of shock by giving the fluid first. Give your antibiotics. Then, if there's a need for vasopressor support, you have to get. Of course, most people with septic shock, they might actually need it because for you to make diagnosis of septic shock, the person must have been needing, vasopressors to keep the blood pressure more than like 65, and also there's going to be persistent elevation of lactate more than 2 milli equivalent per liter or something. We're going to get there and we're going to see. So they might need vasopressors. Norepinephrine is very good. Norepinephrine is a choice, not epinephrine. Norepinephrine, or you can give vasopressin if needed, if hypotension persists despite fluid resuscitation. Then you might need to obtain blood culture. So this is going to be like ancillary measures that we're going to do in investigation. Take blood culture of different samples. It could be CSF, it could be sputum, it could be blood, it could be, wound or anything. The focus of infection. Then anaphylaxis, epinephrine. What's the ratio? 1 in 1,000. Epinephrine, you give that. And you can give adjunct like the antihistamine and steroids sometimes. So don't forget that. Epinephrine is the mainstay. High-end epinephrine. So that's that about. Then for the SIRS syndrome is just more like the same thing, like very similar to sepsis. So just treat the underlying cause of the problem. Pancreatitis, treat it. For neurogenic, you just have to maintain them with pressure support and fluid so that you can maintain the cardiac output. Just give them vasopressors because, of course, there's a vasodilation. So how do you maintain the tone? Give them vasopressor. There's vasodilation. How do I maintain the tone? Give them vasopressor. And how do I maintain, fluid going on, like what's it called, preload and all those things? How do I restore my preload? Infuse with fluid. So if you don't know anything in shock, number one thing is to give fluid. Then consider your vasopressor. Then go and repair the brain or the spinal cord injury. So the first thing that changes in somebody with hemorrhagic shock, especially, is what? The heart rate. The heart rate starts going up. The heart rate starts going up. So the BP will start falling if the person has lost like 1.5 liters. So that means that we might not see significant change in blood pressure until the person has lost like 1.5 liters of blood. So let us look at the question here. So, a 25-year-old woman comes to the emergency department 1 hour after sudden onset diffuse abdominal pain and nausea. She has no serious illness. Menses occur at 27-day interval and last 4 to 6 days with moderate flow. Her LMP was 6 weeks ago. She's sexually active with 2 sexual partners and she uses OCPs inconsistently. She's pale and diaphoretic. Temperature is 37.7. Pulse is 120. Respiration 22. Blood pressure is 75/55. Abdominal examination shows diffuse abdominal tenderness. Pelvic examination shows a normal appearing vagina, cervix, and uterus with right adnexal tenderness. Our hemoglobin concentration is 10. Leukocyte count is 100,000. Platelet is 350,000. Result of pregnancy test are pending. Which of the following is the most appropriate next step in management? C. So this is more like what kind of shock?
A.
What kind of shock?
Hemorrhagic.
Yes. So hypovolemic hemorrhagic shock. So we can see the hypotension, here, and we can see the tachycardia. So things to just look at quickly. Once you see hypotension, just go and quickly look at is this having tachycardia? So once you see that, this is likely to be shock. And we can see the focus here. This person is likely bleeding. She's having like diffuse abdominal tenderness. So just give your fluid first, administer intravenous Lingas lactate solution. Yeah. So that's that. Because you have to correct the shock. Okay. So an 82-year-old man is brought to the emergency department from a nursing home with altered mental status. According to his caretaker, he was disoriented and was shouting obscenities at his co-resident. Over the past 2 days, he has had foul-smelling urine. Temperature is 37.9, pulse is 110, and blood pressure is 80/50. He's oriented to person but not to place and time. Extremities are warm and dry. Other than a weak pulse, cardiopulmonary examination is unremarkable. Placement of Foley's catheter yields cloudy urine with foul odor. This patient is most likely going to have what you're following hemodynamic profile. So now let me try to arrange this well. So what do we expect? Let me just ask. So what do we expect for the cardiac output? Is it going to increase or decrease?
Increase.
It's going to what?
Increase.
Okay, so what do you expect for the PCWP?
Decrease.
Low. We already have our answer. So what do you expect for the SVR?
Increase. Decrease. Low.
Decrease because resistance.
There's a lot of contradiction there. What's our diagnosis? What's our diagnosis?
Septic shock.
So what happens to SVR in septic shock?
It goes down.
Down.
So what about the CVP? What about CVP?
To reduce as well.
Reduce. So D.
So just look at the question, make your diagnosis of whatever is happening there, and just go and pick. So this one can come out. It's very high. They can just put it there. It's not something that we should, get wrong. So moving on to postoperative fever. So fever occurs post-operatively in 40% of situations. That's something. So that means that it's pretty common. So we need to be familiar with the causes of post-operative fever at a particular time. So if fever occurs in the third day, what do we suspect? If it occurs on the fifth day, what should we suspect? On the seventh day, what should we suspect? So we have more like an algorithm. There's an algorithm I put in my head that I use. So the first thing is for the timing, anytime. If somebody have post-operative fever anytime, it could be due to drugs. So drugs can cause post-operative fever at any time. So that's just what to say here. There's no specific timing to drug. It can occur at any time. And what are the common drug reactions that can cause post-operative fever? Number one is our normal hypersensitivities to drug. Some people are allergic to penicillin, they're allergic to. So if we do surgery and we go and give somebody that's allergic to penicillin, they can develop the fever that immediately, or maybe some few hours or some like one day afterwards. So that is hypersensitivity reaction. It could be due to malignant hyperthermia. So they tell us that somebody scheduled for surgery, they put in the what's it called? The anesthetic agent like sevoflurane, isoflurane, whichever one, except nitrous oxide. So don't miss it. USMLE, they can go and put nitrous oxide there. So people will now still go and be picking malignant hyperthermia. Nitrous oxide will not cause malignant hyperthermia. It is the inhaled one, all those volatile one like sevoflurane, isoflurane, and lutein. Those are the ones that have the ability to cause malignant hyperthermia. And we remember the pathophysiology of malignant hyperthermia. There's a problem with the ryanodine receptor. So we need to know the problem too. They can ask, so what's the pathophysiology of this thing? Just don't say that because it's not step one. They can still ask. I'm telling you, they can ask. So what's the pathophysiology of this problem with the ryanodine calcium receptor? And there's a problem with taking up the calcium. There's a lot of calcium being released from the sarcoplasmic reticulum, making the muscles contract. So there's going to be increased contractility. And we remember, when somebody is shivering, the body is contracting, there's going to be heat generation. So there's going to be fever. So somebody having fever, muscle rigidity, electrolyte derangement like hypercalcemia, hyperkalemia, after they have done surgery and they have given local anesthetic agent, inhaled anesthetic agent, think about malignant hyperthermia. And don't also forget the changes that's going to happen to the end-tidal CO2. What happens to the end-tidal CO2 in somebody with malignant hyperthermia? Anybody knows? Neurology or psychiatry or
Increased.
whatever. It's going to be increased. So you see somebody with increased end-tidal CO2, think about malignant hyperthermia, because these guys are having a lot of metabolism. CO2 is being produced. So at the end of each breath, the CO2 level is going to rise. So think about malignant hyperthermia. So you just want to go and give what? What do we give to relieve our malignant hyperthermia? Anybody knows? Anybody wants to remind us? What do we give?
Dantrolene.
The dantrolene. We have talked about antibiotics, penicillin. Blood transfusion reaction. We remember hematology, Dr. Babarinde, hematology. He will have said that people can have febrile non-hemolytic reaction due to blood transfusion. That's the cause of postoperative fever. It is as simple as that. And all those ones can happen at any time. Now, if somebody is now developing fever fast, and what do I mean by fast? Within 1 to 3 days. I have an algorithm in my head that I use. So I think about the mode of transportation. Here is faster than what's it called? Water, which is using boat. But boat is faster than walking. So the one that will happen earlier or earliest is transportation through air. Maybe I'm traveling through the aeroplane or helicopter, followed by me using the sea, followed by me walking. So if somebody is moving through air, what are the challenges that can happen in the lungs? Air, atelectasis or pneumonia. So I see somebody having fever within 1 to 3 days of the surgery. I think about atelectasis or pneumonia. Either the lung has collapsed or the person is having pneumonia. So best next step, I want to order a chest X-ray. Let me see what is happening in that lung. And the way you can prevent that is to encourage incentive spirometry. So if you look at our surgeons, after they do surgery, they start giving all those patients blow, something that looks like toy to be blowing. That is incentive spirometry. You tell them to mobilize. So studies have shown that people that mobilize easily, they get, some hair in and out of the lung. When you are walking, you are breathing very fast, so you get hair in and out of the lung. Any mucus plug that is there might clear, and they will prevent atelectasis. And for pneumonia, you also want to give them, preoperative or even postoperative antibiotics to prevent all this infection like pneumonia, which can happen within 1 to 3 days. So if it's now between 3 to 4 days, I think about water. And what is the water thing? A UTI in my urinary tract, UTI. So, and the main cause of that is because they will forget to remove catheter. So ideally, you should not leave your catheter more than 48 hours. Go and remove it if there's no need. So if you leave Foley's catheter for a long time, the person is going to likely have urinary tract infection by the 3rd day, because you should not put it there for more than 48 hours. So if you leave it more than 48 hours, by the 3rd day, UTI will set in. So that's 3rd to 4th day UTI. Then 4 to 5, walking, DVT in the leg, which is moving as a PE. So you want to encourage early mobilization. That is the most important. So they put it in the question. What do you do to prevent early mobilization? Heparin, compress. I picked heparin. Anticoagulant. That's the best thing. No. The most effective is early mobilization. Get the patient out of bed. As simple as it looks, it is the most effective. So that's what you should pick. Then anticoagulation and, the test talking. Then the last, which is like 7 days and above, after like a week, is our surgical site infection. So the way you can prevent that is they will tell our nurses to be changing the dressing every day. I mean, change dressing here is because of what? They want to prevent surgical site infection. And of course, you also want to give antibiotics, cefazolin, that's a major choice, to prevent perioperative, to prevent, surgical site infection at the end of the surgery. So that's going to be wound 7. So just use the algorithm, everything becomes very easy and simple. So endometriosis, we have a key fact here, and endometritis is an additional cause of postoperative fever after cesarean section, and it occurs on POD 2 to 10. So USMLE, you are never going to pick endometritis as a cause of postoperative fever in somebody that develops fever one day, just one day, within 24 hours of the cesarean section, and go and pick endometritis. That's going to be wrong. So it has to be like within 48 hours and beyond. And we remember the drug. Dr. Babende have told us, he has taught all of us. What is the drug you give to somebody with endometritis? What's the drug of choice? How do you treat? What do you give them? Anybody remembers? Anybody remembers what the code I uses to describe this? Endometritis. I know that people have forgotten. That's why I'm going to say it again. I know. Because the more you hear, the better it will stay. But does anybody remember by chance? So that was the way.
Antibiotics with heparin.
Okay, I get what you are saying. You are talking about septic pelvic thrombophlebitis. That's why you have to anticoagulate. Yes. But what's the antibiotic? What's that broad spectrum that you are giving?
Piperazine tazobactam.
Okay. Well, that can only help majorly with like maybe pseudomonas kind of thing. But I think what you give majorly is Klingent. So that was where he was saying Klingent. Anybody remembers Klingent? Yes. So Klingent, clindamycin, gentamicin, to prevent endometritis. Very, very important. So don't forget the cause of malaria, hypothermia, succinate choline, allotane, and all those things. So check for rigidity, metabolic acidosis, electrolyte derangement. They can easily go into arrhythmia because of hyperkalemia, muscle breakdown, hypercalcemia, and all those things. So cool them immediately, and give them dantrolene. So fever of unknown origin. So this is just a big term for somebody that's having fever, which is temperature of 38.3 degrees Celsius. I don't think I have any question for postoperative fever. I'm so sorry about that. But it's yeah. So, but no big deal. I'm sure we'll be able to figure it out. So, we want to see it in the our question. So fever of unknown origin, somebody having fever of 38 degree Celsius, 38.3 for at least 3 weeks. So somebody's having this temperature reading for at least 3 weeks, and it still remains undiagnosed after 3 outpatient visits. So they've come to the hospital more than 3 times, and they are having this fever for 3 weeks or more. Or somebody has been hospitalized for at least a week, and the person still have this fever. That is fever of unknown origin. Now, what do we do? It is not hard. We just have to break down the category into 4 things. It can either be infectious, and that's the commonest subcategory. Infectious. It can be from malignancy that are occult that we don't know. It could be from autoimmune process, or it could be miscellaneous. So the largest, causes come from the infectious criteria. Now, the thing is, just think about problems that are occult, that are hidden, that somebody might not know. Just like somebody having tuberculosis and the person not coughing, fever. Somebody having an abscess somewhere that is just hidden, and the person having a swinging fever somewhere, fever of unknown origin. Somebody might be having endocarditis, So endocarditis, tuberculosis, and abscess, they are the largest on the list for the infectious cause of fever of unknown origin. In people with HIV, consider opportunistic infection like pneumocystic jirovecii, cytomegalovirus infection, histoplasmosis. Don't forget, we have said it. Sometimes histoplasmosis might just cause like flu-like illness that we won't know. So avium, pneumocystic jirovecii, histoplasmosis can also be a cause of fever of unknown origin. Then for the neoplastic, please, my people, don't limit it to what we are saying here. It can come from colon cancer, lung cancer, breast cancer, cervical cancer, any cancer. So what you are going to do is that you are going to order age-appropriate screening tests for cancer that you think that person might likely have. That's what you are going to do. Of course, rule out all this hepatic renal cancer. I'm just going to drop that abdominopelvic CT. So they tell me that this guy is an alcoholic or this guy is a smoker. High risk for renal cell carcinoma, high risk for lung cancer too. So you can order like chest CT, abdominopelvic CT, to rule out all those things. And there's something about these cancers. There's something you call the naproxen test. So if somebody comes in and the person is having fever for like 3 weeks, person has been to the hospital 3 times and they still don't know the cause, they might want to do this naproxen test, in which they give naproxen, and you will notice that the fever will respond to naproxen. So if the fever responds to naproxen, you want to think about a malignant cause of that fever. As simple as it is, please don't say that I don't know what I'm saying. Just hold on to it like that. So autoimmune causes too. It could be from SLE, rheumatoid arthritis, cryoglobulinemia, Wegener's. Investigate along that. So do all those autoimmune panel. You want to order the HNA, rheumatoid factor, the anchors, and all those things to rule them out. There could be miscellaneous. Maybe the person has just thrown a small clot, DVT, a PE, or the person is having like drug fever from the use of drug, IBD, and whatever stuff. So how do you investigate? And in 10 to 15%, you don't even know the cause. And if you don't know the cause, it's good. Because trust me, studies have shown that later it's going to disappear. It's going to self-resolve. So don't be worried if you don't know the cause. So somebody comes to us now. We have made that diagnosis of fever of unknown origin. What do we do to investigate? So starting, you want to take your history. So any family history of all this kind of thing, any social history relevant, like you want to ask, are you a smoker? Do you take alcohol? So you know what to think about. Sexual history, HIV. Occupation, where do you work? Maybe you've had some exposure somewhere, histoplasmosis and all those things. Dietary, what do you eat? Exposure to pet, cats, animals, and all those things, and travel history. So then you start doing your labs. And the first, you want to start with your complete blood count. Anemia and all those things, you'll be easily able to identify leukocytosis. You see it. Then you want to order your inflammatory markers next, which is your ESR and your CRP. Then you start putting all those cultures too, including urinalysis, urine culture, blood culture, to look for like occult infections, You want to do your PPD test, rule out tuberculosis, then you start ruling out. So everything still follows the algorithm. We have talked about infectious. So tuberculosis is there. PPD, you can order like blood culture, echo for endocarditis. Abscess, we'll have done that by the time we are doing like our scan, but blood culture too can also tell us that there's an infection, because we are going to order like blood culture and also CBC. That can help us, pick if there's an infection somewhere. Then we start thinking about paraneoplastic. We are also going to order CBC that can pick this, and also our inflammatory markers. So CRP, CRP, and our, what's it called? ESR. Both of them, they are going to be elevated here. And we're also going to likely pick these two with our scan. Autoimmune, we start ordering our what? Our panels, ANA, rheumatoid factor, P-ANCA, C-ANCA, and the other ones. You can pick it. Then other miscellaneous, depending on the history, we know what to order. So we don't need to cram what is here at all. So imaging too is going to depend on what are we suspecting. So if you are suspecting lung cancer, chest X-ray. If you are suspecting like abdominal cancers, CT of the abdomen and the pelvis, right? So that's that. How do we treat? So if this guy is on unnecessary medication, drug fever, stop the drugs. If there's any potential side of infection, remove indwelling catheters and lines and all those things, remove them. So people that have a negative workup have a favorable prognosis, because it's going to resolve later, just like we said. So let's I don't think we have a question. So let's see, there's a question here. So this is history of presenting complaint. We are going to get a lot of questions like this in our exam, so we should be ready. Questions like this are the listing history, so we have to be very familiar with them. So history, reason for visit test, follow up 1 week after undergoing evaluation for persistent fever. So this person has been having 4 weeks history of daily fever and chills, and the fever is present throughout the day, and with feelings of fatigue and malaise. And she reports resolution of fever with over-the-counter naproxen. She reports no other symptoms. No recent sick contact or travel hospitalization. The person came to the clinic 2 times in the last 6 weeks, and fever was documented at both visits. So the fever is now presenting again at the 3rd week. So that's FUO automatically. At the last visit, blood and urine samples were collected, and a chest X-ray was performed, and results to be discussed at this current visit. So he's on amlodipine and he's on naproxen PRN for the fever. The other ones are not relevant. So there's fever, we can see fever here, So there's normal conjunctiva, oropharynx, thyroid gland is normal, no problem in examination findings. Blood work appears normal, ESR is good. Liver function test, ALP is elevated, LDH appears elevated. Creatinine kinase, I'm not really sure. I think it should be elevated. CRP is normal. Other urine test is clear, So which of the following is the best next step in the management? So this person smokes cigarettes daily for 20 years, but quit at 42 years. Sexually active. She uses naproxen, and there's resolution of the fever. So what are we going to do for this patient? Anybody? I know that the history is quite scattered, and I don't know, maybe I can give us some time to also go through it. Can give us some time to go through it. Okay, then this. Then the options. What do we think we should do for this patient? Anybody? This patient is on naproxen. Responded to naproxen. What do we think?
It's a malignancy.
Yeah, so we'll talk about naproxen test. So what should we do?
CT scan of your pelvis.
The abdomen.
Just do a CT of the abdomen and the pelvis to look for any underlying malignancy there. That's the best test to do in that list. Okay, so we have talked about sepsis. So this is more like dilating on sepsis again. It's a cause of warm shock. We know that already because of the increased cardiac output. Sepsis can be bad. That sometimes it can progress to DIC, and they start having petechial bleeding, ecchymosis, and abnormal coagulation. So if we do a lab test for somebody with septic shock, what do we see? So it could be, we can see leukocytosis or leukopenia, just SIRS criteria. There could be leukocytosis or leukopenia. There could be thrombocytopenia because of the, hypercoagulability. We are going to notice evidence of reduced tissue perfusion. So end organ issues like problem with the kidneys. So there's going to be elevated urea and creatinine. The liver markers too might be elevated if there's reduced perfusion to the liver because of the absence of oxygenation. So the tissues will be forced to take in metabolism through the anaerobic pathway. So lactate is going to be elevated. There can be problem with coagulation studies like increased INR. And before you can say somebody have septic shock, so they have to have hypotension, requiring vasopressors to maintain the mean arterial pressure more than 65. So the only way they can get the mean arterial pressure to be 65 and more is when you place them on vasopressor. So that's when you can say that, oh, this person has septic shock. And of course, you will have found a focus for the infection. So the person will have fulfilled the SIRS criteria, seeing leukocytosis or leukopenia, increased respiratory rate, reduced blood pressure, then, talking about what's it called? A need for vasopressors to maintain arterial pressure of more than 65. Or you do your labs, you see that the lactate becomes elevated to more than 2 persistently, despite giving fluid. You know that this person is having septic shock, either from a UTI or from a pneumonia or from whatever focus. So you should immediately give the person fluid, continue to place the person on the fluid, and administer your broad spectrum antibiotics. And of course, you have tried to collect cultures from different sites before you start your antibiotics. But the antibiotics that you are going to give the patient is going to be like empiric antibiotics. Then whatever the result of the culture says, you are going to change your antibiotic to that part. All right. Somebody wants to ask a question.
Yeah, please, sorry. I don't get the concept of the naproxen test you spoke about.
So the naproxen test is just that if somebody have malignancy, they kind of respond to NSAIDs. So the fever in malignancy respond to NSAID. So if you give them naproxen 3 days, the fever will come down. It might come back again, and you still need to give the naproxen. Do you understand, Doc? But for the other ones, they don't typically respond to the naproxen if the diagnosis is fever of unknown origin. Do you get what I'm saying? Yes. So that could be So that could be a very fast clincher for you, in your exam. So so sometimes they might need to get ICU admission in which you continue to give them empiric antibiotics, continue to give them fluids, and of course place them on vasopressors to keep maintaining the blood pressure more than 65 millimeter of mercury and optimize end organ perfusion. So if there's any underlying risk factors, just remove the catheters, drain the abscess, so that the condition can resolve. So don't forget, the mainstay of septic shock is just to give fluid, continue maintaining the fluid, obtain your cultures, give your broad spectrum antibiotics and vasopressors to maintain your MEP. That is it. And the vasopressors we are talking about here is what? Norepinephrine or vasopressin. So fluid, antibiotics, vasopressor. Very simple. Very, very simple. So let's look at this. So this is a 80-year-old woman who was brought to the emergency department due to a day of lethargy and confusion. The patient's medical issues include hypertension, type 2 DM, CAD, peripheral vascular disease, stroke. She smoked cigarettes for 30 years but quit after her MI 10 years ago. The patient has been bound for past 2 years due to a stroke. Temperature is 37.6, so there's a fever. This patient is hypotensive, tachycardic, and respiration is 24. She has a sacral decubitus ulcer with prudent drainage and surrounding erythema. Chronic venous stasis changes are present on the bilateral lower extremities. Neurologic examination shows a confused patient who is unable to follow instruction, and the lab result are shown. So sodium is 134, potassium 4.2, chloride 100, bicarbonate 19, urea is 20, creatinine is 2.2, glucose is 250. So invasive hemodynamic monitoring reveals the pulmonary capillary wedge pressure to be 6, and normal is between 6 to 12. And the mixed venous oxygen saturation is 82. Normal is 60 to 80%. Which of the following is most likely responsible for this patient's hypotension? So what do you think this patient is having? No, I'm just asking about diagnosis. I'm not asking about the answer.
Shock.
Septic
Septic
shock.
Septic shock.
So what are we going to pick to be the cause of the hypotension?
reduced vascular tone.
Reduce vascular tone.
Reduced vascular tone. So hypotension is there, tachycardia is there, and the fever. Think about infection. The pulmonary capillary wedge pressure is just borderline, like it's just at exactly upper limit of normal. So we can say it's kind of reduced. And of course, the MVO is increased, which is classic for septic shock. Very important. Okay. So that kind of patient now we continue to maintain on what? On fluid. So they will have told us that this person now they've given fluid is not still working. So antibiotics. So after antibiotics, what do we want to give this patient now?
Vasopressors.
Vasopressors. Very important. So hematologic infection. So we are starting with malaria. So malaria is what everybody know. 5 species: Plasmodium, Falciparum, Vivax, Valley, Malaria, Knowlesi. So the brutal one, which is like, the bad malaria is caused by Malaria falciparum. So falciparum, causes malaria that has the highest morbidity and mortality. So usually within 24 hours, you see them having the fever, having the sweating, malaise, they cannot eat, they cannot sleep, and all those things. So it's advisable that if you are traveling to countries where malaria is endemic, like Africa, Sub-Saharan Africa, and the likes, you must take chemoprophylaxis like atovaquone before you come. You take it while you are there, and even like 4 weeks after you have left. It's because you want to prevent exposure. So use your chemoprophylaxis before you come. When you get there, continue your chemoprophylaxis. Use a mosquito repellent and bed net if they are available, because you want to avoid exposure to the mosquitoes. So what is the typical symptom pattern? This is Africa. We know this. They are going to have high fever, myalgia, they are having muscle pain, headache, sweating. If it's very severe, they have splenomegaly because of sequestration, and we should also watch out for symptoms of very severe malaria like hyperpyrexia, temperature like 40 degrees and more is crazy. Prostration, they cannot stand up, they cannot eat, they cannot do it, they are just prostrated. Impaired consciousness because of malaria. Pulmonary edema, somebody having acidosis with malaria, somebody that's hyperventilating with malaria, those are very bad signs. Those means that the infection is very, very severe. And somebody that's already having coagulation problem, that is bleeding, severe malaria. So don't think about malaria if we see a rash. We don't expect malaria to cause a rash. We don't expect malaria to cause skin ulcer. Malaria is not going to cause eosinophilia because it's a parasite. It's not going to cause lymphadenopathy. No neck stiffness or photophobia. It doesn't cause meningitis. So if you are seeing all these things, don't think about malaria. So how do we make diagnosis of malaria? Just do our blood smear, our blood film, to look at it. So most of the time, to treat malaria from Plasmodium falciparum, which is one that causes a severe form, you might want to give intravenous artesunate and not chloroquine because most of them are resistant to chloroquine. So obtain our what's it called, the smear. The first one we do is the tick. That's the initial one. Just see whatever is happening there. You see the parasitemia, you see the number, but you order the tin later to actually identify the species. Am I dealing with Plasmodium falciparum? Am I dealing with Vivax, ovale, or malaria? So that tin is going to tell us that. So if you order additional tests, because of course they can be bleeding, they're having hemolysis, so you have to order a CBC. So there's going to be pneumocytic pneumochromic anemia with reticulocytosis because of the hemolysis. There's going to be a reactive, reticulocytosis to that. And sometimes if we have good resources, we might need to do serology. In the US, I feel they can even isolate somebody with malaria. You can think it's something very bad, but in our own territory here in Africa, malaria is just basic stuff, and we might not need to go extreme as ordering fluorescent antibody tests to make diagnosis of malaria. So you see somebody having all these features, feeling frustrated, having fever, malaise, bleeding, hemolysis like hematuria, having deranged liver function test and all those things, hypoglycemia. You might want to obtain history. Have you traveled? Maybe this person is in US. Have you traveled to Africa recently? Or maybe India or some tropics like that. And if you get history, you might want to quickly do a thin thick film to look at the malaria parasitemia, which we are going to see as this kind of trophozoites like that. So, and also don't forget the Schaffner granules, which are specific for the let me quickly show us what it looks like. The Schaffner granules, for the Vivax and the Valley. So once you see the blood work showing some extra immature trophozoites, something like this, we know that this is likely to be the Vivax and the Valley. So these dots that are the Schaffner stuff we want to pay attention to. So once you see that, you might want to consider adding primaquine, for the hypnozoite that might stay latent in the liver. So don't forget that. So somebody can have cerebral malaria in which we have a lot of parasitemia, occluding the vessels of the brain. So they can start having headache, they start convulsing, hemorrhage, retinal hemorrhage, neurologic problems, delirium. We see this a lot. When I was in pediatrics in Abeokuta, we see this a lot, cerebral malaria. That diagnosis used to make me laugh because it sounds somehow you're having cerebral malaria. So we treat it a lot back then. So this is not the kind of patient you want to be giving oral agent. So you want to admit this kind of person and place on intravenous what's it called, artesunate, But for the uncomplicated one that most of people have, just give oral agent, oral artemisinin combination if it's available, mefloquine, atovaquone, or anyone that we have, just give orally. So chloroquine is out of it now because of resistance. And don't forget, if you are making diagnosis of the Vivax and the Valley, you must always add primaquine. But before you start your primaquine, what test do we want to order? Hematology. Before you start primaquine, what test are we going to order?
GCSPD.
GCSPD assay to rule out, GCSPD deficiency before you start primaquine. So don't forget, anybody going to endemic region, use your prophylaxis, which could be atovaquone, proguanil, or mefloquine, anyone you want to use for 2 weeks before you travel. Continue when you travel, and after returning, continue it for 4 weeks to prevent the attack. So, what are the contraindications to some of the anti-malarial? Primaquine, this is PDRC. Mefloquine. I see mefloquine as an irritant. It irritates the heart. It irritates the brain. Because it irritates the brain, there's seizures, there's psychiatric problems. Because it irritates the heart, there's arrhythmia. That's mefloquine for you. Then, atovacone proguanil cannot be used by pregnant people. It can be secreted in breast milk, so don't give it to breastfeeding mothers, and it can also cause renal problems. So chloroquine can cause problem with the eyes. It can cause skin issues, itchiness, and even provoke psoriasis. So we know the complication of malaria, cerebral malaria. They start having altered sensorium, confusion, seizures, retinal hemorrhages. Think about cerebral malaria. They can have severe hemolysis, hematuria and the likes. Problem with renal, of course, if there's bad hemolysis, you start having myoglobin being released into the blood. Myoglobin is toxic to the renal tubules. It's going to be a lot that even these what's the name of the pigment that helps us mop the hemoglobin pigment? Anybody remember hematology? This is hematology now. What's that pigment called?
Haptoglobin.
Haptoglobin. Haptoglobin has been mopped up. All the hemoglobin, everything is just going to be released like that into the into the renal tube. I'm supposed to say hemoglobin, not myoglobin, because it's not muscle. So all the hemoglobin are released like that. The renal tubules, and they cause AKI. They are going to cause like acute tubular, necrosis which can lead to renal impairment. They can have a lot of, inflammatory process affecting the lung, having non-cardiogenic pulmonary edema. So that's why they're having features of pulmonary edema, and they're having hyperventilation. So think about non-cardiogenic pulmonary edema from malaria. They can be hypoglycemic, they can have lactic acidosis, liver issues, and even increased susceptibility to gram-negative bacteria. So what are the other mosquito-borne problems that we should expect? So, and what is common to all of them is that they are transmitted by the Aedes mosquito. So malaria is by the Anopheles, the female Anopheles, but the other ones that we have here is Aedes mosquito. So, one thing that's common to the three of them, which is chikungunya, dengue, and Zika, is that they can have rash, fever, and malaria. So take them one by one. Chikungunya is the first, and I have some notes here for us. So now, somebody with chikungunya will have had travel to tropical region where you have a lot of Aedes mosquito, and the person is going to start having fever. They are going to have malaria. But what should catch our eye is when the question states that the person is having bilateral polyarthralgia. They're having fever with joint pain. They palpate this joint, the joint are swollen due to effusion, synovitis, or even periarticular edema. Think about chikungunya. Now, they can also tell us that the person is having maculopapular rash. So, this could be chikungunya, this could be dengue. What we now quickly go and do is to look at the labs. Is there anything pointing towards bleeding stuff like thrombocytopenia? Is this person having like lymphocytosis or like any bleeding problem? If you are not seeing any derangement of the bleeding parameter like thrombocytopenia and the likes, don't think about chikungunya. Think about dengue, because most people with dengue with chikungunya only have fever, headache, rash, the joint pain, and the swelling. That is all. They don't have anything beyond that most of the time. So what we just want to do is just to manage the symptoms. So you can give them like analgesics for the pain. You can give, sometimes if the joint problems are not getting deformed, they are getting very severe, you can give DMAT, methotrexate and the like, to take care of the joint issue. But generally, the management for chikungunya is supportive. Now, somebody with dengue, they will start having the fever. They will start having, the maculopapular rash too. They're having malaria, and okay, this is a question. So they typically have the fever, the headache, the rash, they have neutropenia, and they will have bleeding problems. So they can be bleeding. They can be having thrombocytopenia. So we want to see somebody that's having bleeding problems, hemorrhagic shock, fever, headache, rash, neutropenia. Think about dengue. Just think about dengue. So the bleeding problem is there, thrombocytopenia is there, the shock, and of course when you check them, low white blood cell, increase LFT. So immediately, because of the bleeding problem, you want to give them fluid and blood product immediately. And there's a vaccine for dengue. There's a vaccine for dengue. So one way to prevent it is prevent mosquito bites. That's common to chikungunya, to avoid mosquito bites. Cover yourself. But for dengue, had the vaccine. To prevent dengue. Zika too can be transmitted by the mosquito. But if we don't see mosquito in the question, just go and pick sexually transmitted route. Like, it can be sexually transmitted and it can be transmitted by the mosquito guy. So it's a flavivirus. And it typically causes the fever, the rash, headache, conjunctivitis. So in our step 1 then, the acronym that I used to use is CPR. So CPR is the acronym that I used to use. And that's conjunctivitis for the C, the rash, the pyrexia, which is a fever. P for pyrexia, fever, and the R for the rash. So you have a rash, fever, conjunctivitis, headache. Think about Zika. So Zika can cause a lot of problems. Guillain-Barré is one of them. It can cause Guillain-Barré syndrome. It can cause congenital Zika problem, in which you are going to be seeing features of MOM. Step 1, MOM. So you are going to be having ocular problems. The baby is going to be having ocular problems. They can be having motor problems, and what's the last M now? Can I even remember? I think they have
Microcephaly.
microencephaly. Thank you very much. I've forgotten myself. Microencephaly. They have small head. They have ocular problems and motor problems. Now, if you do imaging and you try to look at their head, they are going to be having ventriculomegaly. So, although the head is small, from the last time, the head is small, but the ventricles on imaging is going to be enlarged. So, the reason why the head is actually small is because of the reduced cerebral volume. The reduced cerebral volume, the brain matter itself is reduced, but the ventricles are going to be enlarged. And you're going to see basal ganglia or subcortical calcification. So we are seeing subcortical calcifications or basal ganglia calcification with all the features of MON that we have said, the motor problem like seizures, contractures, the ocular problems, and the microencephaly. Think about, Zika. With the imaging finding, think about Zika. Okay, let us look at some questions here that I have. So, this is a 37-year-old woman who comes to the emergency department due to 5-day history of fever, chills, malaise, headache, and fatigue. The patient temperature has fluctuated between 37 and 41 degrees Celsius. She has been taking ibuprofen, which improves the fever. The patient took a 7-day vacation to Southeast Asia a month ago. The temperature is 39.9. Blood pressure is 110. On examination, the patient appeared tired and had mild scleral icterus. There are no oropharyngeal lesions, lymphadenopathy, or rash. The lungs are clear on auscultation and no cardiac murmurs are present. The liver is slightly tender to palpation. The spleen tip is palpable below the left costal margin. Neurologic examination shows no sign of meningeal irritation. Which of following is the best next step in the diagnosis? What do you think this person is having?
Malaria.
So what do we do next?
Blood smear.
Just order a blood smear and this person is going to be fine. All right. So let me see. I think I have another one here. So this is a 35-year-old woman who was previously healthy, comes to the office due to 3 days history of fever and malaise. The patient's symptoms started after she returned from a 2-week vacation in the Caribbean. For the past day, she also had marked pain in her hands and wrist joints. The patient does not take tobacco, alcohol, or drugs. and she's in a monogamous family relationship with her fiance. Temperature is 39.4, blood pressure is 110, pulse is 98. Examination reveals clear lung fluids, normal heart sound, and no murmur. The abdomen is soft and non-tender with no hepatosplenomegaly. She has a macular skin rash on her trunk and extremities and mild cervical lymphadenopathy. There are no oral ulcers. Musculoskeletal examination is notable for swelling and tenderness of the bilateral hand, wrist, and ankle joint. Lab is as follows. So there is hematocrit of 38%, a platelet is 120,000, leukocyte is 29,000, neutrophils is 82%, lymphocyte 10, AST, ALP 32, 24. Which of following is the most likely diagnosis?
Chikungunya.
Chikungunya. So why are we picking chikungunya here? Why?
The bilateral swelling of the
Bilateral
joints.
swelling of the joint.
Yeah.
Fever.
Fever.
You can see the rash. You can see the rash.
Endemic.
So
Travel to endemic area.
travel to endemic area. Exactly. And they told us that the joints are swollen and they are tender. So this is likely to be chikungunya. Okay.
Just thrombocytopenia.
Yes. So the thing is, you can see that they did not put dengue here. So yeah, so chikungunya would be the most appropriate option to pick. I know that the thrombocytopenia is there, but this person is not even having like bleeding. You can see that the person is not really bleeding. So much of what this person is just having is just the joint symptom. But they are not going to be wicked and be putting dengue here. Although chikungunya can also present with all this during many of the labs, but it's not very common. So this is actually a very good question for us. So don't say that because we are seeing all these thrombocytopenia and the like, and we should not pick chikungunya. No, still pick, that's still the most logical answer to pick here. So it's chikungunya. So, but most of the time, people with chikungunya will not have bleeding problems and be having the petechial rash and the likes. Somebody else want to ask a question?
Yeah, please. I just want to ask, what also rules out infectious mononucleosis here?
Infectious mononucleosis. Well, you don't expect arthralgia. Do you expect arthralgia to infectious mononucleosis? No. And again, infectious mononucleosis is very common in people that are young. This person is 35. It's not likely. It's not very likely. And infectious mononucleosis is not likely to cause leukopenia. So, because there's going to be reactive what? Lymphocytosis. So, this person having leukopenia is not likely. The age is not likely. The joint symptoms is not likely. So, so that rules out infection. Infectious mononucleosis, you see, fever, fatigue, sore throat. Fever, fatigue, sore throat, the lymphadenopathy. Then you go to the abdomen, hepatosplenomegaly. That's all most of the time. They can have rash too, but you won't say anything about the joint. So once you are saying joint stuff, think about another thing. Does that answer your question?
Yes, it does. Yes, it does. Thank you.
You're welcome. Okay. So moving on to, I think that's yeah. Okay, somebody wants to ask a question.
Yes, please. I got a little confused. What if they had put both of them, dengue and chikungunya?
I think the answer will still be chikungunya, because people with dengue, most of the time they are going to have like bleeding problems. Like the person might still have some kind of bleeding, maybe petechial rash or some form of DIC or something. Although dengue is a spectrum, but I think you are not going to find yourself in that situation. Trust me, you are not going to find yourself in that situation. They are very similar. Dengue is a spectrum. You can have dengue fever, you can have dengue shock syndrome, and all those things. But you will not, have yourself in that situation. And that thing they will also put in dengue that also helps is they have retroorbital pain. So they will tell you that they have like pain in the front of their head, like a form of headache in the front of their head. They are going to have neutropenia specifically, and you see like thrombocytopenia, bleeding issues. So think more of dengue. But once you see more of joint, and little of bleeding, pick chikungunya.
Okay, thank you.
So yeah, you're welcome. But don't worry. You will not find yourself in that situation. Yeah. Okay. So Lyme disease. So we are moving. We are done with the mosquito borne now. We are looking at the Lyme disease. So we'll go for a break once it's 4 p.m. my own time. So the tick borne. So we're starting with Lyme disease. Lyme disease is what we are all familiar with. It is caused by a spirochete that we call Borrelia burgdorferi. And it's being transmitted by it's being carried by a vector, which is what the Ixodes tick. So this guy can transmit BAB, so which is the Borrelia, the Anaplasmosis, and the Babesia. So BAB, just like my name, BAB. The BAB from our step 1, the BAB. So the Borrelia, the what? The Anaplasmosis, and the Babesia. So usually in the US, once they see anything related to these Ixodes, so somebody comes with Lyme, they will rule out Anaplasmosis and all these Babesia too. So in that person, they will do tests to rule them out quickly. They are that very prompt. So somebody with Lyme disease, how do they present? Very important. They are going to have fever, because this is definitely an infection. So there's going to be fever from the Borrelia infection. They are going to have a rash. There's going to be a rash, but what is that rash? We are going to talk about it, and that's the erythema migrans. They can have other non-constitutional symptoms, fatigue, headache, myalgia, blah, blah. But what I want to say here is that the infection typically occur if the tick has fed for more than 36 hours. So if they put in the question that person moved from one part and went to this part of the US, I don't know the countries there, but I don't think we need it. Northeast, Northwest, and the Pacific. And the person has been there for more than 36 hours. And the person developed all these things. Know that the tick, or even if the person has not developed all these things, most likely the tick will have stayed there for more than 36 hours. So you might want to do something, which we are going to talk about shortly. So the infection from this Lyme disease occurs in 3 stages. So you have the primary or the early localized disease, you have the secondary and the tertiary. So what is peculiar to the primary? So after the tick has fed for 36 hours, that area starts developing a lesion that you call erythema migrans. So you see something that looks like this. See this initial part, you see this part, I see this part. So this is what we call like the target lesion, that is erythematosus. So this is erythema migrans. I'll call it erythema migrans because you see the lesion here today, tomorrow it will appear in another part. It could appear in the thighs, it could appear in the abdomen again, it could appear in the leg, like that, like migrating from one part to another part. That is erythema migrans for you. So that's the primary lesion or the early localized. It's one place. Now, secondary early disseminated. So the rash will now start migrating to that part. That is secondary early disseminated. What happens? So that brings us to the concept of FAME. So they start having facial nerve palsy. That's going to be secondary or the early disseminated disease. So they can have bilateral facial nerve palsy. They can have arthralgia, which is a HAME. They can have meningitis, myocarditis. Meningitis, myocarditis. Mind you, the meningitis is going to be what? Lymphocytic, USMLE. Don't forget that. Lymphocytic meningitis. So they show us the CSF analysis. Don't go and be looking for, the usual one that we usually pick is bacteria, strep pneumo, and the likes. And they will put Lyme in the option and will be scared to pick it. Please, if everything is in keeping with Lyme, confidently pick your answer. Because all these things is very common in the US. So we should not say that, Lyme, it looks very rare. And we are doing, what kind of bias is that? We are saying it looks very rare. I'm not going to make diagnosis of Lyme. What kind of bias is that? Anybody? What do we call that? So because you think that disease is rare and all the investigation is pointing you to that disease and you are not making that diagnosis, what is that? We've done it though, my people.
Permission. Something.
I'm correct.
No, I said it. I said there's one animal that is very rare.
Zebra.
Zebra retreat.
Zebra, yeah.
That is zebra retreat. So they run away because they feel that the zebra is very, very rare. That this thing cannot be diagnosed. So they will now retreat. Zebra retreat. I'm sure that if we see it in the option, we'd actually remember. So it's fine. So that's just that about the FAME. So don't forget the the F, which is standing for the facial nerve palsy, which could be bilateral, the arthralgia for the A, the hem for the meningitis, which is lymphocytic meningitis, and myocarditis, and the E for, I think, the rash. So the rash, the erythema migrans, which could be what? Migrating, don't forget. Then the tertiary stage. So this is when the arthritis that they have, this arthralgia, becomes chronic, lasts for more than 3 months. And they are now having features of what? Subacute encephalitis. They start having mood change, personality changes. Things that they don't do before, they start doing it. They cannot remember anything. That is encephalitis. So now, this classification is important in the exam because it's going to guide your treatment. So anybody with primary and secondary, you can give them oral, not IV. Oral doxy. Oral doxy, you can give them. Very, very important stuff. Give them oral doxy. The person is pregnant, you can give them amoxicillin for pregnant people. Although there have been a study that have shown that provided that you are not using doxy for more than 21 days, it is still saving maybe children, or like pregnant people. No, let me say children. Children can still be saved if you are not using for more than 21 days. But once it's getting to more than 21 and there's an indication for doxy, go for something else. Go for amoxi immediately. So for tertiary, so they use IV ceftriaxone. That's what you should pick. Once you are seeing anything about encephalitis or heart problem, or even though it's secondary, but they're having heart problem. So heart problem, encephalitis, meningitis, give IV ceftriaxone. Very, very, I must emphasize that, please. Heart and brain problem, IV ceftriaxone, because you need something to penetrate all those structures. IV ceftriaxone, heart and brain, IV ceftriaxone. So let's look at the diagnosis. You want to make a diagnosis. If it's early, you work with clinical diagnosis alone. So you just look at the rash. Oh, this guy is having erythema migrans. And they used to say that, okay, you have to get that the person is, in an endemic area. Please forget about it. In the exam, you don't have time to be looking at, is this person from Texas or from Mississippi or something. What's the erythema migrans? You know that the answer is likely going to be like early line. So you might not need to do serological stuff, whatever, because it takes time for it to get positive. But if somebody is having feature of early disseminated or late disseminated, so you need to calm down. So am I having the rash? Okay, fine. The rash is there. It's having like the arthralgia. Okay, I can see feature of like meningitis there. Okay, these guys are likely having like disseminated form. So the next thing you want to do is to do your ELISA test. So you are checking your IgM and IgG. So if you get it present, fine. You can say that this person have the disseminated form. Please don't forget, you don't work with clinical alone for disseminated. Go and confirm with your ELISA. Very, very important. This is important. Go and work with your ELISA. If you do your ELISA and ELISA is equivocal, so your test is not saying it's positive or it's not saying it's negative, then you have to confirm with your Western blots. That's the only time you do Western blots. In fact, even in HIV, we don't talk about Western blot again. So you only talk about Western blot here if the ELISA test is what? Equivocal. So you don't start with Western blots too because of high false positive rate. So how do you treat? If you find a tick in somebody's body, use forceps to remove it and disinfect the area immediately. It's as simple as that. So for people with early problems, the rash, just give them doxy orally. If they are pregnant, give them amoxicillin. So if you want to use amoxicillin, just use it for less than 21 days in young people so that it doesn't start discoloring their teeth and they start having, cartilage problem. So for people with much more advanced problem like CNS problem, cardiac problem, you can see here, just give them IV ceftriaxone. CNS problem, cardiac problem, IV ceftriaxone. So if we see somebody with the rash, with the symptom like the arthralgia, and the person has gone to endemic area, so you can start empiric treatment, and that's by giving doxy. So the best way to avoid it is just to prevent yourself from getting bitten by the tick. That's the only thing. But sometimes somebody might need a prophylaxis. And what is the drug for the prophylaxis? It's still doxy. Just give one dose. But they must meet like 4 criteria before you can consider for prophylaxis. So has this person been in that area for more than 36 hours? Because there's no way we can actually know if the tick has been attached for more than, there's no way. We don't know when the tick attached. We don't know. There's no way you can know that this is when this tick attached to this person. But what can give you an idea is how long has that person been in that environment. So if the person has been in that environment for more than like 2 days, you can be sure that okay, it's likely that the tick will have been attached for more than 36 hours. And you must start your prophylaxis, within 72 hours after you have, removed it. Because the next thing is, if the person has gone to the bush, the person has been exposed to the tick, and you saw the tick in the person's body, you use what? Forceps to remove it, and you disinfect the area, and you commence your doxy immediately within 72 hours of removal, within 3 days of removal. And before you can consider doxy, make sure that the person doesn't have any contraindication to doxy. So local rate of infection of tick with Borrelia is 20%. There's no way we can know this. So the major 3 criteria is what? The person has been diarrhea for 36 hours. You remove the tick and you start it within 72 hours after tick removal, and the person doesn't have any contraindication to doxy. Those are the things that warrant giving prophylaxis. But if this criteria is not met, you don't give the prophylaxis. Just wait. So if the person has been in that area for like 12 hours, and the person went to the bush where they have ticks, and the person has just been there for 12 hours, the criteria has not been met. So you have to observe that person. Let's see, is this person going to develop erythema migrans? So if the person develops it, give your doxy. So tick testing is a common incorrect answer choice. It has no effect on management, and it will not perform on the Lyme disease work. Have we talked about tick testing today? No. So don't go and be testing for tick. So if it's early disease, early localized, clinical. If it's early disseminated or late disseminated, what do we do next? Anybody?
ELISA.
ELISA. And
ELISA.
if the ELISA is equivocal, we confirm with our Western blot. It is as simple as that. So don't forget the indication for prophylaxis. Have you been in that area for more than 36 hours? Have you seen the tick and you have removed it? And is this person okay to take doxy? Once that is met, just give your doxy, to prevent that. So let's come back in 17 minutes. Let's come back in 17 minutes. So 6:20, 16:20. Okay. Thank you, everyone. Hello, everyone. Welcome back. So we are moving to babesiosis now, and this is just another tick-borne protozoal infection. That is caused by a similar vector like the Lyme disease, and that's the Isodes tick. So it's caused by the Babesia, organism. So the Babesia microti, that's the cause of babesiosis. So it's just more like malaria for the white people. So they have like features of severe malaria. They can have like intravascular hemolysis, anemia, and jaundice from the hemolysis. And by the time we do the blood smear, just like the way we do for malaria, we're going to be seeing the Maltese cross. So just the trovozoid like crossed at like 4 quadrants. I know that we know what it looks like, so let me just show us in case I've forgotten what the Maltese cross looks like. Babesiosis. So once you see something like this, we know this is likely to be babesial infection. So it's very, very common in people that are having problem with the spleen. So anybody that have problem with the spleen, they find it very difficult to eradicate that organism. Or people with some background immunocompromised state or malignancy. So we may find some risk factor in the question, we may not. But the ones to keep in mind includes like asplenia, immunocompromised status, or malignancy. So, and we used to say in step 1, the treatment is AA. So you give atovaquone with azithromycin. So azithromycin with atovaquone. AA is the treatment for the babesiosis. So if it's very severe, you might need to administer the azithromycin intravenously, especially if the person is unconscious, they cannot take drug orally. Just give the azithromycin intravenously and the atovaquone. So that's all about babesiosis. I don't think I have any question. There. Okay, I do. Let's check it. So, a 32-year-old man comes to the emergency department due to 5 days history of intermittent high fever, chills, and drenching sweat. He also has malaise, fatigue, and dark urine. The patient has no medical history other than splenectomy after motor vehicle collision 10 years ago. He drinks alcohol on social occasions and does not use tobacco or recreational drugs. The patient is in a monogamous relationship with his wife. He lives on Long Island, New York, and works in Manhattan as a software programmer. The patient has not traveled outside the country but recently went camping in New England and found 2 ticks on his legs when he returned home. Temperature is 39.5, blood pressure is 110, pulse is 160. Mild scleral icterus is present. There are no enlarged lymph node or rashes. A mildly tender liver edge is palpable 3 cm below the right costal margin. Laboratory results are as follows. Hemoglobin 9.4, reticulocyte 10%, platelet 110, leukocyte 12,000. LFT, total bilirubin is 4.3, alkaline phosphatase is 92, aspartate aminotransferase is 62, alanine is 74, LDH is 300. Which of the following is the most likely test to confirm the diagnosis in this patient? Anybody, what do we think of here? What's our diagnosis going to be?
Lyme's disease.
Why? Why is it Lyme's?
Babesiosis.
Yes. But somebody said Lyme. Why?
Oh, sorry.
Okay, mistake. Okay. So that's babesiosis infection. We can see the feature of hemolysis here. The guy is having fever, chill, just like we expecting someone with like malaria kind of thing. Then the person having dark urine. So that means there's like hemolysis. And they told us that this guy is having a risk factor. He had undergone splenectomy, and he had not traveled outside the country, so it's not going to be malaria. So most of the time, they are going to be in the US. They are not going to travel to a region where malaria is endemic. And he's having jaundice, hemolysis, dark urine, and the liver is enlarged because of, the sequestration and the likes. Then there's feature of the hemolysis. You can see the reticulocytosis, 10%. We can see the hemoglobin count dropping, 9.4, so that's likely to be babesia. So what we can do is, even though we are not sure that it's not malaria, the best thing is just do the blood smear. So if it's malaria, we are going to see it. If it's babesia, we'll see it. So we'll be able to make our diagnosis from there. All right. So moving on to Rocky Mountain spotted fever. So this is caused by Harald. We have Rickettsia prowazekii, Rickettsia rickettii, and the like. So the RR, which is Rickettsia rickettii, is the one that causes the Rocky Mountain spotted fever. So it is being carried by the American duck tick, the Demarcanthur, not Ixodes. So Ixodes is just BAB, Babesia, Anaplasmosis, and Borrelia. So let me mention something about ehrlichiosis here, because I saw that there's a part that talks about ehrlichiosis that, just side note. So ehrlichiosis is a disease that transmitted by the Lone Star tick, not the Ixodes tick, but the Lone Star tick, and it's very common in South Central and the Southeastern US. So they can have constitutional symptoms: headache, fever, chills, altered sensorium, and the likes. They don't typically have rash. But they can have derangement in blood work, like leukopenia, thrombocytopenia, elevated liver enzyme. But what I just want to say here is that one thing to always look out for with respect to ehrlichiosis is just the lab studies. So sometimes you can see that there might be leukopenia, but you see that relatively the monocyte count is going to be high. So because this ehrlichiosis guy, they typically infect the monocytes. So if you see like monocyte count being higher than normal, and the person is having constitutional symptoms like fever, headache, malaise, joint pain, sorry, not joint pain, myalgia, just myalgia, headache, malaise, and you look at the monocytes high, or they show us like a plus smear and they tells us that they are like morule inside the monocyte. Morule inside the monocyte. Think about ehrlichiosis. So the treatment is always doxycycline. If you can't remember anything about the treatment of all those atypical organisms, just pick doxycycline. It's going to be correct most of the time. Yeah, somebody has a question.
Sorry, did you say their leukocyte count is high? But they said leukopenia in this.
Yeah, so I said monocyte. Monocyte is part of the cells too. So monocyte specifically is the one that's going to be increased in them. So have that at the back of your mind. So there's the infection grows within the monocyte. So they can tell you, they can spell it out that there's a morule of this ehrlichiosis in the monocyte. So that's just step one stuff. All right. So the Rocky Mountain spotted fever is caused by Rickettsia rickettii, and it's being translated by the American dog tick that we call it Dermacentor. So it's common in this area. I don't think we need to memorize it. But one thing that is peculiar to Rickettsia rickettii is that it causes damage to the endothelial lining of the capillaries. So it can cause inflammation of the vessels with eventual damage of the endothelial lining. So that's why they typically have some petechial bleeding, very common in them. So just like we can see in this person now, this petechial bleeding involving the palm and sole. So if you have somebody having like a rash, particularly petechial rash involving the palm and sole, think about Rickettsia rickettii. Think about Rickettsia rickettii. So it usually starts as, complaint of fever, headache, then the rash will now start. So they say they are feverish, they're having headache, the rash will now start. So how does the rash start? So the rash is going to start here at the wrist of the hand and at the ankle of the leg. Then it will spread downwards. So from the ankles, it will go to the sole. From the wrist, it will go to the palm. So if you have a rash that is spreading in that kind of manner, think about Rickettsia rickettii. So it might be macular initially, but later it will now change to the petechial or the purplish rash that will now start moving inward. So from the wrist, ankles to the soles and the palm, then inwards to the abdomen, the legs, like that. So sometimes it can progress to DIC. So DIC is a very serious complication of Rickettsia rickettii infection. So you want to quickly, treat with doxycycline to prevent progression to DIC. So it's usually a clinical diagnosis. Get the history that person has been through, like a mountain of all these areas in this Arkansas, Missouri, and the like, and suddenly the person start developing fever, headache, and they notice a rash that started at the wrist or the ankle that moves downwards to the sole and the palms, then centrally to the body. Think about Rocky Monkey. They can also help us, and they tell us that they saw maybe some tick bites or they were able to see some ticks in the body. Think about Rickettsia rickettii. So empiric treatment is always with doxycycline. But if they are pregnant, within the first 2 trimesters, you can use chlorphenicol. So chlorphenicol is very, very useful in the first 2 trimesters of pregnancy. So we've talked about the pattern of the spread of the rash. Please don't forget it. I don't think I have any question there. Okay. So moving on to infectious mononucleosis. So this is very common in young adults, like 14, 15, 13 years. It's not typically seen in people that are old. It's caused by Epstein-Barr virus infection. So this is also known as kissing disease. So people that kiss a lot, because of exchange of saliva, they can get infectious, So between the young age group that are trying to explore, kissing everybody, they can get infection. So what's the presentation? So they have fever, pharyngitis. So pharyngitis in form of sore throat. They'll tell us that the person is having sore throat, pharyngitis, and fatigue. This fatigue, don't ever forget about it. So somebody having fatigue, fever, sore throat, many things will come to our mind. But infectious mononucleosis should be part of those things that should come to our mind. So they can have generalized lymphadenopathy too. If you open the throat, we are going to be seeing exudate, in that throat, tonsillar exudate, a maculopapular rash. So starting from the head, they have fever, their body is tired, they have cervical lymphadenopathy. You open the throat, they're having throat pain. We see like exudate in the throat. We now go down to the abdomen, we palpate the abdomen. There is evidence of hepatosplenomegaly in a young person. Think about infectious mononucleosis, very, very important. So sometimes they can have mesenteric lymphadenitis, in which the lymph node that is going to be enlarged had the mesenteric lymph nodes. So they can have what we call like pseudo appendicitis. So like, right lower quadrant pain and the likes. So sometimes they can be misdiagnosed as streptococcal pharyngitis and they will be given amoxicillin and they will not develop rash. So watch out for that. So somebody having like suspicion, if a doctor have a suspicion for streptococcal pharyngitis, or even the mother thinks maybe it's just normal bacterial infection and they give amoxicillin and they develop a rash, you have to rule out infectious mononucleosis. So there are very, very close differentials for infectious mononucleosis, and CMV infection is one. HIV is another close one. HIV, CMV, and toxo, they are very, very important differentials. But the most important differential here is actually CMV. So people with acute CMV infection can have infectious mononucleosis-like presentation, in which they are going to be having fever, fatigue, sore throat, with exudate, hepatosplenomegaly, and maculopapular rash. So by the time we do a test, which we call the heterophile antibody test or the monospot test, it's going to be negative in people with CMV, in people with HIV or toxo. But in people with Epstein-Barr virus infection, the enterophile antibody test is going to be positive. But sometimes, if we do it too early, because we've not allowed enough time for seroconversion, so it may be negative. So, so in that situation, if we still have a very high um, index of suspicion, we can do the EBV specific antibody test. So usually, this might be positive. If it's actually a case of what's it called, Epstein-Barr virus. So the EBV specific antibody test may be positive in them at that time. So if we do the monospot test and the EBV antibody test and they are both negative, your answer should be CMV infection. It should be CMV infection. Most likely, it's going to be CMV. If we don't see CMV infection there, let's go and pick HIV, acute HIV, because people that have HIV acutely, within the like first 1 or 2 weeks, they can start developing something that looks like this. They tell us that they're having fever, they're having sore throat, they can be having some oral ulcers, lymphadenopathy, and something that looks like infectious mononucleosis. So you have to rule out HIV in those kind of people. So we are going to talk about HIV shortly and we'll talk more about that. So if we do even though this is the best next step, order the heterophile antibody test. If that is negative and you have high index, do your EBV specific antibody. So you can also do other ancillary tests like the complete blood count, which we are going to be seeing relative lymphocytosis with, more than 10% constituted by the atypical T lymphocyte reacting to the proliferating B cell, because the cells that actually proliferate in response to the Epstein-Barr infection are the B cells. But to try to get rid of those B cells, the T cells will become atypical. They start differentiating to abnormally large vacuolated T lymphocyte, I'll call the atypical T lymphocyte. So we can also identify that on our blood work, So because of affectation of the liver, so there's elevated transaminase, alkaline phosphatase, and total bilirubin. So don't forget, lymphocytosis in EBV is actually due to B cell proliferation. So don't go and pick T cell. It's not a T cell problem. That's why all those lymphomas, they can be caused by Epstein-Barr virus infection because it can drive B cell proliferation. So what's the treatment? Supportive. There's no antivirus that is available for it. No antiviral agent is available to treat Epstein-Barr virus infection. So, but there are some indications to give steroid. And the way I look at it is, whenever there's anything affecting the blood work, thrombocytopenia, or like acute hemolytic anemia, that's serious. Aside the lymphocytosis that we know. So somebody having like autoimmune hemolytic anemia, thrombocytopenia, that's already causing like bleeding, or the person is having like airway problem, the throat is already choking due to the tonsillar enlargement, you might need to give steroid to relieve that symptom. So the person is already almost choking from tonsillar enlargement, or the person is having severe thrombocytopenia or acute hemolytic anemia, you have to give steroid immediately. So what are the complications of infectious mononucleosis? CNS, they can have aseptic meningitis, encephalitis, Guillain-Barré, transverse meningitis, and the like. So EBV can cause all these things: transverse meningitis, the spinal cord, the brain, meningitis, encephalitis, optic neuritis. It can cause splenic rupture. So that's why, because of the splenomegaly, we usually tell the boys or the children to avoid contact sport for at least 4 weeks so that it doesn't rupture. If it ruptures, they can have bleeding into the peritoneum, in which there's going to be referred pain to the left shoulder. So don't do any contact sport. Don't play football, basketball for 4 weeks. It can cause upper airway obstruction due to tonsillar enlargement, and we have said it that you have to give them steroid immediately. There could be bacterial superinfection, because of the inflammation at that area. So there could be bacteria coming in, like streptococcal pharyngitis. So they can have fulminant hepatic necrosis. Don't forget, this thing can affect the liver too. So, and it's even the commonest cause of death in the males. So the liver can undergo necrosis at the end of the day. They can have autoimmune hemolytic anemia. Dr. Ryan will have said this in hematology. So EBV infection is the cause of autoimmune hemolytic anemia. So alongside with the thrombocytopenia, you have to give them steroid to treat it. And we know the features of autoimmune hemolytic anemia. We know what we are going to see. We know the spherocytes. We are going to see all those things. So don't forget about it. And they can also cause nasopharyngeal cancer. EBV can cause a lot of things. It can cause nasopharyngeal cancer. It can cause, Hodgkin lymphoma, primary CNS lymphoma, and all those things. So nasopharyngeal carcinoma too is another one, in which they will just start having swelling in the back of the nose. So they can be having recurrent nose bleeding, epistaxis, headache. You can go to the lymph node and the neck. You just see them having a very serious neck swelling. So we have to rule out nasopharyngeal carcinoma. Okay. So moving on to HIV. HIV is very, very important. Very, very important for our exam. So it is a positive sense diploid RNA genome. So HIV has 2 RNA strand that we need to convert to a single DNA. So that's HIV. And it majorly targets the CD4 positive cells. Not only the T cells, but anything that contains CD4. Macrophage, dendritic cells, T cells, all of them, they are being attacked by HIV. So transmission is usually by sharing infected body fluids, either through sexual intercourse, intravenous drugs, like sharing injectables and all those things. And also people that engage in receptive anal sex, because this one is highly associated with tearing of the anal mucosa. So it's very, very risky to transmit HIV. So men who have sex with men, they are in serious trouble because of tearing of the anal mucosa and spread of HIV. So MSM, which is men having sex with men, is still the the greatest cause for HIV transmission in the US. But if you look at it globally, heterosexual still dominate. So that's like, men to women or women to men. So what is the genome of the HIV? How does it look like? This is how it looks like. So we have to identify the double strand of the RNA. So RNA that has a diploid RNA, 2 strands, and it has the reverse transcriptase enzyme, which this guy cannot do without, attached to one of the strands. And the genome itself is enclosed immediately by a capsid protein. And this is very, very important in the testing. The capsid protein P24 that includes the genome is very, very important in the testing. Then all those things too are now surrounded by the matrix protein, which is P17. I don't talk about this, it's not very important. Then of course, covered by lipid envelope. Now there are some proteins that are now attached to that, some of the capsid protein, matrix protein rather, and you have the GP 120 and the GP41. So this is the GP120 here, this is GP41 here. So we call them the envelope proteins because they are attached like to the envelope. So now, what do they do? I think I should explain that here. So we have talked about the diploid genome, 2 RNA, and now this RNA codes for 3 structural genes that we call the envelope gene, the GAG gene, and the pole gene. So the envelope, the GAG, and the pole. The envelope, the GAG, and the pole. Now, what is the envelope protein? The envelope protein codes for a protein that we call the GP160. Now, the polymerase enzyme, the protease enzyme from this HIV, the protease enzyme will now come and split this GP160 into GP120 and GP41. So this is GP120, this is GP41. Now, what does GP120 does? The function of GP120 is to help to attach to the CD4 positive T cells, macrophage, and also the co-receptors. So what will happen is that when somebody gets infected with HIV will get into the bloodstream and it will start looking for the macrophages and the T cells. And when it finds one, it's going to use its GP120 to attach to the CD4 receptor on the macrophage and the T cell. But this T cell and the macrophages also have additional co-receptor. Particularly on this macrophage, you have the CCR5, and on the T cell, we have the CHR4. These are co-receptors, right? So after the GP120 binds to the CD4 receptor on the macrophage and the T cell, there's going to be a conformational change that is going to allow the GP120 also to bind to the co-receptors on the CXCR4 and the CCR5 on the macrophage so that they can achieve a tight binding. So after that is achieved, GP120 is done with its work. Then what will happen now is that the fusion protein, which is GP41, will now move closely and fuse. So with this, they'll be able to fuse with this macrophage and the T cell. So the function of GP120 is just to dock, just to connect with the CD4 and the CCR5, CCR4 of the macrophage and the T cell. The one that will now make them fuse is the GP41. Now, that is all about the action of the envelope protein. Now, the next is the GAG protein. So GAG protein is just the matrix and the capsid. So the capsid, which is P24, and the matrix, which is P17. This one are just there to cover it, to just form a shield around the genome. That's what they do, GAG. Then the pole. So the pole, encodes the proteins. So 3 major proteins: reverse transcriptase, integrase, and protease. Now, what will happen is that when the HIV genome has entered the macrophage or has entered the T cell after binding with GP120, fusing with GP41, they have now gained entry into the macrophage. or they have now gained entry into the T cell. Now, that cell that they have entered is not a virus. That is a cell from an eukaryotic organism, which is human being. So that cell has a capacity to proliferate on its own and do replication and all those things. So they are going to use that to their own advantage. And they know that mammalian cells, eukaryotic cells, they work with DNA. We don't work with, mRNA. We proliferate our DNA, we take it to mRNA, and we take it to protein. That's a logical sequence. We don't start with mRNA and be distributing mRNA. So what they will now do is that they want to mimic mammalian cells. So what they do is that once they get entry into the macrophage and the T cell, they will now start recruiting the activity of their reverse transcriptase. So they will now convert their double-strand RNA, they will convert it to a DNA strand. So there's going to be DNA in the macrophage. There's going to be viral DNA too in the T lymphocytes. Now, from there, because it's already in the DNA form, the replicative machinery of the macrophage or the T cell cannot take it from there. So they will now use their intrinsic machinery to replicate it, to take it to mRNA, just like normal way we do our stuff. They take it to mRNA, and from mRNA, they take it to what? To protein. So that is how they're able to synthesize their viral proteins, which includes what? The envelope protein, the gag protein, and the pole protein. So that's the activity of reverse transcriptase, to convert it from this double-strand RNA to DNA. But don't forget, after they have converted it from double-strand RNA to DNA, they need to integrate it into the genome of the macrophage and the T cell. So what are they going to use? They are going to use their integrase to integrate it. So when they now integrate it into the genome of the macrophage and the T cell, so that one is now going to start converting it to mRNA and to protein. So they will start, all the macrophage and the T cell will be producing viral protein. Instead of them producing their own protein, they are not going to have time for that again, because the HIV virus has integrated its own DNA into the genome of the macrophage and T cell. So they start producing viral protein, which is envelope protein, gap protein, and pole protein. But don't forget, the protein is going to be like a long segment. So they need something to start cleaving it, that, okay, this amino acid from here to here is going to code for envelope protein. This one from here to here is going to code for envelope protein. How do they now do it? So they will now employ the activity of their protease enzyme to now start cleaving the protein into tiny, tiny bits, so that they can assemble and form new viron. So that means that in the question, if they tell us that somebody with HIV is given a protease inhibitor, what is that going to do? So what that is going to do is to prevent formation of new viron, because there's no way it can package itself, into smaller bits, because it cannot splice the protein. Because if you want to form a new viron like this, a new HIV virus, you need to assemble it, assign the RNA, and assign some proteins to it, which includes the capsid protein, reverse transcriptase, matrix protein. But if you cannot use protease to cleave all those things, there's no way you can form new assembly. So in the process, you are going to be forming immature viron. That's the activity of your protease inhibitor. If you give somebody that's having HIV integrase inhibitor, what that one is going to do is that, fine, the HIV virus is going to be replicating, it's going to have its RNA, but it's going to get entry into the macrophage and the T cell, but it will never be able to integrate its RNA into the genome of the macrophage and the T cell, so they cannot replicate. If you give reverse transcriptase inhibitor, it will not be able to convert its RNA to DNA to even integrate. So it's practically useless. So that's the mechanism of action of some of the drugs that we use. And another one is that there's another drug we call Miraviroc. And what that one will do is to inhibit the CCR5 receptor. So don't forget, we have said it that before they can even gain entry, they need to use their GP120 to bind to the CD4 receptor and also the what? The CCR5 and the CCR4 receptor. So Miraviroc is going to come and occupy the CCR5 side so that GP120 cannot bind. So there's no way they can gain entry into the cells. That's Miraviroc. That is why before you give Miraviroc, you have to do what we call genotyping. You have to do what we call genotyping to actually see, if that HIV virus like has an affinity to be binding to what's it called, the CCR5 or the CCR 4 receptor. Don't worry, we'll get there. We'll shed more light on it. What else am I going to say? I think that's that about the drugs. Just to give you heads up about the way some of those drugs work. So how is HIV transmitted? So sexual transmission, sexual transmission, we don't have to waste time. It's very common in people that are uncircumscribed. So they have a very high chance, because if you are uncircumscribed, the prepuce is still there. So during sexual intercourse, there's a very high chance of bruising. So which can allow like exchange of sexual materials and all those things. And also people that play with sex toys that are coated with the body fluid. So somebody with HIV, have inserted the sex toys into their private part. Somebody now start playing with that kind of sex toys too. They can get it from there. People with concurrent STI too, they have a very high risk of getting it, because the macrophages flood the infected area. So if somebody has trichomonasis or syphilis, that person's genital area has a lot of macrophages already infiltrating that area. And don't forget, what HIV uses to gain entry is to bind to macrophages. So the macrophages are already there waiting. So any small thing like this, HIV don't enter. So that is why people with concurrent STI, they have a very high risk of developing HIV infection. So that's why in the US, anybody with chlamydia, syphilis, and all those things, you automatically want to screen for HIV. Next best step, go and screen for HIV. So mother to child, from blood, breast milk, vaginal fluids, especially breast milk. Now, here I'm going to make a very, very important statement. So if you look at the question and you could identify that the patient is in the US, developed country like in the US, or it is not stated, assume that mother is from the US. In them, if the mother have HIV, do not breastfeed that child. Never breastfeed that child. Place the child on formula. If the mother is from Africa, person living in Africa or developing country, from what you can see in the question, and they ask, what are you going to do if the mother is HIV positive? In that kind of situation, pick big breastfeeding, continue breastfeeding. The idea is that, so it's believed that people that reside in countries like the US, they can afford good formula, nutritious, prepared from clean water. So there's a very little chance of the child developing diarrhea and all those infection from the formula. But in Nigeria or India or other developing countries, because of poor access to good clean water, there's a risk that if you go and be saying that, go and be giving formula, they can be giving formula that is not even well prepared and can complicate the whole stuff. So in them, you advise the mother to still continue breastfeeding while you place the mother on the heart. And of course the baby should have gotten the Zidovudin shot. So if it's in the US, don't breastfeed. If it's in developing country, breastfeed. Don't forget it. You will need it somewhere later. So blood transfusion, of course, sharing needles, sharing needles, blood transfusion too, can also be a means through blood transfusion. So ways in which we don't spread HIV: contact with urine, fecal matter, sweat, saliva, even organ, kissing, toileting, and everything. So, but it can only be gotten through kissing if the person has a bleeding lesion in the mouth. So what are the things we use to monitor disease progression? You can do the CD4 count, you can do the viral load. So CD4 count can tell you, the risk of immunosuppression, that how badly immunosuppressed the person is. You look at the CD4 count. What's the risk of the HIV, progressing to a very much more severe problem, like having opportunistic problem, opportunistic infection, and all those things. So CD4 count will tell us that, and CD4 count also tells us if we need to give some prophylaxis against some of this infection, and also how well is the person responding to the drug, the antiretroviral therapy. CD4 count is going to tell us. For people that will check their viral load, the reason why we check viral load is majorly to check their response to the drug, and also to prognosticate that is this person very bad or very poor, and is this person going to have a high chance of spreading the infection to another person. So somebody with very high viral load, if you want to say, okay, does this person has a high chance of spreading it, and we are looking at CD4, we are just joking. What we have to look at is viral load. Higher the viral load, higher the chance of spreading. So once you keep it less than 20, you know that, oh, we are doing well. We can continue that drug. So this is just a chart that tells us the changes that happen when somebody gets infected with HIV. Now, we don't need to cram this thing. We just need to understand what we are looking for. So I'm going to start with the blue line. We can see that the blue line is starting when the person has a primary infection. So if somebody gets infected with HIV today, the first thing that will happen, that will be present in that person is going to be, which one do you think is going to be present? Is it going to be the antibody or the genome? Anybody?
The genome.
The genome. The genome.
Yeah.
So it
The
makes
genome,
sense. It makes sense for us to assume that this blue line is going to be HIV RNA, just like we can see here. So you don't need to even master the curve. Just look at it. Which one is starting from 0? If this one is the one that they marked, that which one is this curve representing? So this is going to be the genome, because this is starting. It started rising immediately the person was exposed to the HIV genome, HIV RNA. Now, let's look at the red line. The red line is dropping. It's the one that is dropping. And don't forget, we said the major cells that are affected by HIV is what? What cells are affected by HIV? What cells?
Macrophages.
Yeah.
macrophage and T cells.
CD4
Exactly.
cell.
Exactly.
CD.
So the CD4 positive, T cells majorly. So what is going to be dropping here, is going to be the CD4 positive T cell. That is it. Now, if we look at this orange line, this one is appearing after 1 month. So it means that in a way, it is after seroconversion has happened. So it is logical for us to say that this is actually the antibody against the GP, against the glycoprotein. So this is going to be the anti-glycoprotein antibody, or the what? Anti-envelope antibody. So once you look at it, okay, what time is it appearing? Oh, after 1 month, okay, seroconversion, that's going to be the antibody. What time is it happening? Oh, immediately, that's going to be the genome. This one is dropping. This must be the cells that are being killed by the HIV, the CD4 positive T cell. Now, the one that plateaus and later drops is going to be the CD8. Because don't forget, we did not mention CD8 when we were talking at all. So that one will still be there. In fact, it will get to a time that it will even rise to even attack. What thing they happen now? What's killing all this? To want to surge to try to respond, but later they will calm down. Okay, let's just see how it goes. Then later it will be caught in the process and it will die off. So once you see this, plateau, just know that the one that is not really involved in the process, that is your CD8, cell. Now, what are the stages? So look at the first one at 0 months, to the first month. That's going to be a window period. Why? Because that is the point between the point of infection and the point of seroconversion, where you have your antibody being present. So that's going to be the window period. So that's like a 1 month kind of. Now, there's something you call the acute HIV infection period, kind of. So that's more like the point in which you have the seroconversion and like, how do I put it? Like just constitutional symptoms. You don't have a specific symptom that actually points to HIV. Like you don't have. So the word is, there is no age specific illness at those times. So that is not the time that we are going to be seeing somebody having esophageal candidiasis or the person having PCP. So that's just more like, an acute response to the HIV infection. So that's when the person is going to be having the sore throat, the fever, just like we said, something that looks like infectious mononucleosis, the lymphadenopathy, the fatigue, the oral ulcers. So that can happen within like the first, 2 weeks to 1 month of infection. Then after that time, the person can now be latent for as long as 8 years. No symptom at all. Maybe they can just be having low-grade fever, seborrheic dermatitis, just low-grade thing that is not very, very specific for HIV. No clinically apparent symptom that is very bad like that. So it can be there for like 8 years. So that is why we still need to be screening everybody for HIV because of clinical latencies. If there's no clinical latency, then it means that, once we see someone with HIV, we know. So, but because of clinical latency, which can be as long as 8 years, you have to always screen for HIV. So before it now gets to 8, so by the time it gets to 8, at that time, this guy is going to be less than 200. You can see that the time where they are calling it 8 is this point. So, and at this point, the CD4 count is already 200. So once it gets less than 200 beyond, so that is 8, CD4 count less than 12. Or if the person is already developing 8 specific illness like PCP, Kaposi, Cryptococcus, just know that that's 8. So that's just a summary of this table. Now, we talked about acute HIV. Sometimes in like 10 to 60%, they don't have any symptom. They don't undergo this acute HIV. But sometimes they can have it, in which they start having, what I've talked about, flu-like symptoms like fever, sore throat, cervical lymphadenopathy, maculopapular rash, ulcers, GI symptoms like that. So at that point, if you check their RNA load, it will be high. But seroconversion has not yet occurred. So, and sometimes too, people can undergo the clinically latent period for like 8 years, just like we said. You're not going to see anything bad. They can just be complaining of that they're always tired. I'm just always tired, and we see that they're having generalized lymphadenopathy, USMLE step 2. Somebody having generalized lymphadenopathy, rule out HIV, rule out syphilis, rule out Epstein-Barr. Generalized lymphadenopathy, HIV, syphilis, Epstein-Barr, infection of mononucleosis, very important, very, very important. Generalized lymphadenopathy, head to toe, problem. Secondary syphilis, high on the list. HIV, very high on the list. So they can just be having candidial infection. So somebody having candidial thrush or vaginitis, it is not age defining. Don't ever pick that, this guy, see thrush for him mouth. This guy don't get HIV. No. It can just be that the person is using, steroids for asthma or something. So they are not specific for HIV. But if the person is having, if you do endoscopy and you are seeing that person is having dysphagia from candida until otherwise proven, go and do personal step HIV test. Combined HIV, test. That's what we are going to do. So because of the clinical latency, we need to screen. We have talked about that. So this is the oral thrush. What is 8? CD4 count less than 200, or the person is having any age-defining lesion like Kaposi, PCP, Cryptococcus, disseminated shingles, a lot of them. Toxo, name it, a lot of them. So, so most people that don't receive treatment, they die of complication of HIV. Yeah, we'll talk about that. Now, the best next step is now to understand how do we make diagnosis of HIV. How? So the first test you want to order is your what? Your antibody P24 combination test. Very, very important. Very, very important. You want to order HIV 1 and 2 antibody, P24 antigen combination immunoassay. So you want to test for the antibodies and for the antigen. Is it going to be there or not? Now, one thing about this test is that if either of them is positive, you are going to get a positive result. So you don't need both of them to be positive for this one to be positive. No. Once any of this stuff that is being tested is positive, you get a positive result here. So you do your combination immunoassay, which is testing for your P24, which is a matrix antigen, and your HIV-1 and HIV-2 antibody. HIV-1 is very common in what's it called? In the world. HIV-2 is in West Africa. So if you do your combination immunoassay and it's negative, you can confidently say that this person doesn't have HIV. If you do your test and it is positive, then you now proceed. You don't stop there. You proceed to do your differentiation immunoassay. Now, what are you looking for here? Fine, it is positive, but I want to know, is it HIV-1 or HIV-2? So what you can do is to check for the antibodies individually. So there are like 4 possibilities. Either you find out that it is only antibody of HIV-1 that is there. Fine. Differentiation immunoassay, not combination, differentiation now. So you can find out that it's only the antibody of HIV-1 that is there. HIV-2 is negative. So you know that, okay, this is HIV-1. You could find out that the antibody of HIV-1 is negative and that of HIV-2 is positive. So this is HIV-2. You could find out that both of them are positive. This person is having combination. Both HIV-1 and 2 is there. Problem. Or the person is negative to both of them. So that's what you call indeterminate. Now, in what situation can you have indeterminate differentiation immunoassay test, but a positive test from your combination test? So the only condition is if only what is positive here initially is your P24. So that is what carried it downwards to this level. So that means that if we do the test too early, within 2 weeks, and it's only the P24 antigen that is positive, and the person has not undergone cell conversion, even despite the fact that the antibodies are not there, we are still going to get a positive test here. So by the time we proceed downward to go and do the differentiation immunoassay, testing specifically for the antibody of HIV-1 and 2, we are going to get a negative result. So at that time, what we're now going to do is to now check for the what? Genome. Because we have said it, that genome is always going to be present, regardless of the time. But we cannot jump straight to genome everybody because it is very expensive. NAT is not something cheap, So once you get indeterminate and you've gotten a positive result in the combination, so you just go and do your HIV-1 NAT, nucleic acid amplification test, which is a form of PCR, right? So if it's positive, you cannot say that, okay, this person has HIV-1. There is no HIV-2 NAT yet. So if it's negative, just say the person is negative for HIV-1. So the diagnosis is likely to be HIV-2. So don't forget the best initial test, combination antigen antibody test, which is a 4th generation test. Very important. It is a 4th generation test. You're testing both the antigen and antibody. It looks complex, but very simple. By the time we go for the group discussion, we are saying all these things, they'll just be thinking one is a genius, but just very simple stuff. Combination for antigen antibody, you are checking for the P24 and the antibody against HIV-1 and 2. So you need to do it after 2 weeks. If you do it within 2 weeks, it's likely that it's only the P24 that will be positive at that time. So to now confirm, you now do the HIV-1 and 2 differentiation immunoassay. So you prefer this by Western blot, please. So you pick whatever is happening. Now there are some special scenarios. You have to be very careful. Now, if somebody is having acute early HIV, that is not the time to be doing combination tests because P24 or immunoglobulin, the antibody rather, they will not be positive. So in that test, in that situation, the test to do is going to be the NAAT. So which is going to be the HIV, PCR RNA test. If somebody is having perinatal HIV, the best test to do is going to be the PCR RNA test too. Why? Because if we go and be relying on combination immunoassay, we'll just be getting false positive. Why? Because if a mother is positive for HIV, this is the baby. Immunoglobulin will always cross. IgG, don't forget. IgG crosses the placenta, true or false?
True.
True.
So the IgG of the HIV will cross the placenta and go to the baby. Please, my people, the fact that this baby is having IgG of his mother, does it mean that this baby is HIV positive? No. So the only thing that can happen that we can say that this baby is HIV positive is if the HIV virus itself has moved to the baby and the baby is now having the HIV genome. So that is why we go ahead and do the HIV PCR RNA or the NAAT test to look for the genome. We don't rely on combination immunoassay. I know that part is going to raise question. So I'm listening.
So why is it that it's only the IgG that crosses? Can the virus not cross?
So the virus can cross. So it depends on the circumstance. It depends on the circumstance. But what we are saying is that we are not going to be starting with combination immunoassay because if you are working with combination immunoassay, it can give you false positive test. Because I'm just giving like a hypothetical scenario. Let's say that the only thing that has crossed in that child is the antibody. The virus has not crossed. Let's say maybe because the mother is on heart. Now, if this mother is on heart and the count is less than 20, there's a very little chance that the genome is going to enter this baby. But the antibody is going to be in the mother. Doctor, are you following me? That antibody is going to be in the mother, even though the mother is on heart. Do you know that if we test that baby, the baby is going to be positive for the antibody? Yes, because the mother have the antibody. Even though she's on treatment, she will still have the antibody. And if you go and carry that baby now, you go and test the baby, you will not be getting false positive. You will not be saying, the baby is HIV positive. No, the baby is not HIV positive because the mother is on heart. In that mother, the RNA count will have been so low that you will not find anything in the baby. But the immunoglobulin will have moved to the baby. So can you see the reason why we don't work with the combination test?
Yes.
So the best thing is just go and do the NAT to see, does this baby have the genome or not? That's the best one. It is as simple as that. So don't forget the conditions to make diagnosis of AIDS. So the common ones is just to look for CD4, is it less than 200? 8. Are you finding Toxo, PCP, Cryptococcus, Kaposi, Eosinophilic shingles, which one again is there? There are a lot. JC virus activation, all those things. This guy is having AIDS. And they also talk about the fact that if the percentage of the CD4 positive T cell have dropped to less than 14% of total, then you should be wary for it. So when do you screen? USMLE step 1, step 2. USMLE step 2. Everybody between the age of 15 to 64 years should get a one-time screening. Are you 14 years? Don't pick HIV screening. The baby is 14. Don't pick HIV screening. Don't pick it unless the person is engaging in high risk sexual behaviors. But normal person between the age of 15 to 64, you have to screen for HIV one time. And you have to do it annually in people with high risk. So someone that is using drugs, intravenous drug, themselves and their partners, because they are obviously going to be sleeping with their partners. So the partners who are at high risk, screen them for HIV. So there's this guy that uses drug, married to the wife, but the wife doesn't use drug. Because of the fact that she is with the man that is abusing drug intravenously, both of them, annual screening for you. Sex workers, annual screening for all of them. Partners of the sex workers, annual screening for them. Partners of people with known HIV, annual screening for them. People that engage in men-to-men sexual intercourse, annual screening for them, because all these are high risk for HIV. So we also do it routinely. People, when they come for their antenatal visit, you have to screen for HIV. Antenatal screen. Each pregnancy, you have to screen. You don't say, Motisheni last baby, negative, because the problem. Do it again, because you don't know what will have happened. So each time you are coming for your prenatal screening, do HIV screening. People with new STIs, we have talked about this. So somebody is newly diagnosed for syphilis, newly diagnosed for chlamydia. The best next step, check for HIV. You get exposed to infected body fluid, mistakenly got splashed with blood from someone with HIV or something. Immediately screen. Immediately give them what's it called? The post-exposure prophylaxis. Then you now continue the screening, 6 weeks, 3 months. So they get splashed now, high risk. They get their test. Is this person HIV positive or not? Quickly do it. Then immediately you give them post-exposure quickly. Then you check them again, screen them again in 6 weeks, screen them again 3 months before they can now say that they are clear of HIV. Very important stuff. Very, very important stuff. So, opportunistic infections in people with HIV. So, the biggest risk factor is what? Is CD4 count. So, yes. Question.
Yes, please, sir. What's the medication you give immediately for prophylaxis when you get splashed?
Yes, we are going to get there. So what you give is
Okay.
tenofovir. You give tenofovir, alafenamide, TAF, and emtricitabine. Emtricitabine. I don't know the short form for emtricitabine. Well, we are going to get there. Then you had integrase inhibitor, maybe dolutegravir or something. This is for post-exposure. If it's pre-exposure, you just use these two only. Tenofovir plus emtricitabine. So a prostitute now wants to go and have sex. A man now wants to go and have sex with a prostitute. High risk behavior. They will take pre-exposure. And loba you, please God be with me. I want to cover myself with my pre-exposure. Somebody wants to have sex with another man. A man wants to go and have sex with another man because they know that there's going to be high risk for tearing the anus. They take their what? Their pre-exposure. So we're going to get there and we're going to see it. So yes. So the opportunistic infection, the tendency of those opportunistic infections happening depends on the CD4 count. So, and we are going to look at the spectrum. So the first spectrum is when it's less than 500. So what are the things that they are likely going to have? And I used to remember step 1. I used to use the word my happy, Kaposi. My happy, Kaposi. That's what I used to say for step 1. So you just have to remember the first two. There's no acronym for the first two. Once you open the mouth of somebody with less than 500, you always see thrush. Once you open open your mouth, you see oral thrush. And the closest differential for oral thrush is what? Oral hairy leukoplakia. And don't forget, you cannot scrape one, you can scrape the other one. So oral hairy leukoplakia for HPV, oral thrush for candidial. Both of them, they are present somewhere with less than 500. Then my happy Kaposi now comes in. My Mycobacterium tuberculosis. They're very common. They can be reactivated. Happy human papillomavirus. So think of anything caused by human papillomavirus, squamous cell cancer, what, all those things. We can see it. Then Kaposi, skin lesion for Kaposi. Skin, not lung or GI. The skin lesion of Kaposi is very common in people less than 500. So you just see this, And when we see the biopsy, when you do the biopsy, you are going to see perivascular, spindle, what's it called? Cells, which indicate the endothelial cells being invaded by the viral cells. So you see lymphocytic infiltration of the perivascular spindle cells. Very, very important. So that is if it's less than 500. If it's less than 200, I think about the problem with the brain. I think about problem with the lungs. So for the lungs, I think about histoplasma and pneumocystic. In fact, nobody in this class can forget pneumocystic as number 1. So, and we have talked about what you are going to see. The what? The ground-glass opacity. Bilateral, reticular opacity. We do the silver staining, we see the cigar shape, yeast, right? The next thing to do is to look at the severity. And what do we do to calculate the severity? What do we calculate? Anybody remembers? PCP. What did we say?
CD4 count. Oh, sorry, what are you?
So
Sorry, what's the question?
what do we calculate to look at the severity of the problem, of the presentation of PCP, so that we know if we are going to add another drug to the normal drug that we give them? Do you remember?
The CD4 count.
No, it's not the CD4 count.
The PaO2.
We calculate the AA gradient. We calculate the AA gradient. If it's more than 35, or we look at the PaO2. If it's less than what? Less than what?
15.
No. Less than
70.
what? Less than 70. It's just 35 times 2. It's just 35 times 2. If it's less than 70, or A gradient is more than 35, that's when you know how to add your steroid to whatever you are giving. Very important. No, it's not less than 50. So people say less than 50. So that means that if PO2 is 60, we'll not give it. Please, that's going to be wrong. So, yes. So then the second one for the lung is histoplasma capsulatum. So we already know the symptoms of histoplasma. Horse. Don't forget the horse. Whenever you see anything related to the horse, and you see the yeast in the macrophage, just go and treat histoplasma. Then the brain. Number one is JC virus. So they can have progressive multifocal leukoencephalopathy. So this just means that there's going to be multifocal asymmetric lesions in the brain on MRI. So you do MRI and you're going to be seeing multifocal asymmetric lesions. So on the MRI, you see some areas that's going to be hyper-intense. So it depends on the level. On T1, it's going to be hypo-intense. On T2, it's going to be hyper-intense. Or they tell us that there is area of demyelination that is non-enhancing, that is not picking up contrast, gadolinium contrast, JC virus, multifocal area, JC virus. So how would they present? So they can be having focal neurologic deficits. Usually, they will tell us that the person is having aphasia, hemiplegia, ataxia. They cannot walk, ataxia. The walking is abnormal, hemiplegia. They cannot talk well, aphasia. It can affect the optical lobe, vision problems, visual abnormality, So, have that. They can have seizures, JC virus. But what's the imaging saying? That's going to be what is going to clinch, be the clincher for us. Then the next one for the brain is dementia. So they can have HIV dementia. When we do the imaging, we are going to see areas of cerebral atrophy. Think about HIV dementia. And they can also have HIV-associated nephropathy. What kind of histology pattern is HIV-associated nephropathy going to show us? Renna, Dr. Randy have talked about this. Renna, what's histology pattern?
FSGS.
FSGS.
All
Fantastic stuff.
segmented.
FSGS, fantastic stuff. So people with HIV, sickle cell, heroin, obesity, all those things, FSGS, very, very important stuff. You know what to look out for. That's the time to be looking out for features of nephrotic syndrome, plus TD, proteinuria, and all those things. Yes. So CD4 count less than 100. Just think about the other ones. Anything that is not within what we have said. So Bartonella, Candida, but Candida of esophagitis, don't forget. Don't forget esophagitis. Bartonella causing bacillary angiomatosis. So if you are seeing CD4 count of 150 or 200, and they put lesion that looks like Bartonella, don't pick it. Go and pick Kaposi easily. Know that it's going to be Kaposi. It can never be bacillary angiomatosis if it's not less than 100. It is as simple as that. And if you biopsy bacillary angiomatosis, you are going to see neutrophilic inflammation, not lymphocytic of Kaposi. CMV, you can only see it in someone less than 100. It has to be less than 100. And you are going to see creep, colitis, retinitis, esophagitis, encephalitis, pneumonitis. So we are going to talk about that one too shortly. Then Cryptococcus neoformans meningitis, encapsulated organism, is going to be very thick, very thick. And we know the stain, the way it appears on Indian ink. Please, let's check it again to see. Cryptosporidium, watery diarrhea that is very chronic. Just go and do, stool analysis. Best next step, stool analysis, and rule out Cryptosporidium. For CMV, the colitis is going to be bloody. So somebody having bloody diarrhea with HIV, I don't need to be ordering any test. Otherwise proven, the answer is CMV. Bloody diarrhea, HIV, CMV. Simple as that. HBV, all the lymphomas in the world. CNS lymphoma, B-cell lymphoma, HBV. But it's going to be solitary. If you are seeing multiple ring enhancing lesion, HIV patient, think about Toxo. And don't forget the bad guy, avian. It has to be less than 50. Its own is even mad. It's not even 100. It has to be less than 50. Don't forget what we said about Togo. How will they present? Anybody remembers the way they will present? Avian. Anybody remembers? What did we say?
Atypical chest infection.
What?
You said presentation, right? They can have atypical chest infections.
Atypical chest infection. What else? So sorry.
GI symptoms,
Yes, GI symptoms. So
diarrhea.
fever, diarrhea, weight loss, and all this. Please, 1 minute, 1 minute, my people. I'm coming. I need to respond to something quickly. I'm so sorry. Please, I'm so sorry. I'm so sorry about that. So let's continue with our discussion. I hope you can all hear me. Can we still hear me? Hello. Okay, thank you. So we have talked about avium. So just like somebody said, fever, lymphadenitis. Just look out for the GIT symptoms, very high so diarrhea, weight loss, abdominal pain, nausea. Avium. Then the brain abscess, multiple ring Hansen lesion on MRI, think about Toxo. So that is that. So how do we manage and prevent HIV? So everybody should be on lifelong heart. They take it for life. Even during pregnancy, they are still taking it. So we have to encourage 100% adherence, cancel on street adherence, and because we don't want resistance to happen. So we also have to do like resistant testing to see like which one is it going to work with. Is it going to work with this drug, or this person is immune to this drug, or the HIV will not be able to respond to that drug, blah blah blah. So then we measure the viral load and the CD4 count at the time of the diagnosis. We measure the viral load and the CD4 count at the time of diagnosis, and we have to be doing that every 3 to 4 months. So why do you measure the viral load? Just like we have said, you want to see if this person actually responding to therapy, and we don't expect it to increase. So we don't expect it to go beyond 50. But if it's increasing or it has gone beyond 50, after 4 months of treatment, you know that you have to evaluate that treatment and change the regimen. So the goal is to keep it reducing to undetectable levels, which is typically less than 20 per microliter. Then you continue with therapy. So the point where you have little or no transmission risk is if you have kept it below 20. That's the RNA. If the RNA is below 20 counts, 20 copies per microliter, we have won against HIV. So the initial regimen is just 2 nucleoside or a nucleotide reverse transcriptase inhibitor and 1 integrase inhibitor. So the same treatment for post-exposure, prophylaxis, and the same treatment for treatment. The same thing. 2 nucleoside or nucleotide reverse transcriptase inhibitor and 1 integrase. So, but you can replace your integrase with a protease, Now, let's look at those drugs one by one. So this is just a class. We have the reverse transcriptase inhibitor, the nucleotide reverse transcriptase inhibitor, and a non-nucleoside, which includes efavirenz, nevirapine. These are so the ones that inhibit attachment to Reaviroc that attach to CDER5, the ones that prevent enfuviratide. So this one prevents fusion. So if this one is preventing fusion, what is it attacking? Anybody?
It's
GP41.
GP41, because it prevents fusion. As simple as that. And fusion 41. Miraviroc, that's CCR5. Okay, then the Gravil are the integrase. They're very boring stuff, but look at it. So, so the first class, we have the nucleoside or nucleotide reverse transcriptase inhibitor. So we call them the NRTIs. So we only have one example of nucleotide, and that is tenofovir. That's the only example we have in this world. And what I want to say is that the difference between a nucleoside and a nucleotide just depends on phosphate. So once you phosphorylate a nucleoside, it becomes a nucleotide. Now the acronym to remember all those drugs is ADELS, ADELZS. So A for abacavir, D for what drug do we have here? I think the danosine, yeah. I used to forget that drug. Danosine. E for hemtricitabine, L for lamivudine, Z for zidovudine, and S for stavudine. So abacavir, didanosine, hemtricitabine, lamivudine, zidovudine, stavudine. We know everything. And of course, the nucleotide is going to be the tenofovir. There are two formulations for tenofovir. The one we like is the TAF, alafenamide. So I'm sorry, I might be a little bit biased. So for the Yoruba people here, it's very easy to remember. So from the word alafenamide, so that's what everybody wants. Alafenamide, because it has less adverse event. But the other one, the soproxil, is bad. It can cause kidney problems and osteoporosis. So you have to be very careful of giving TDF because of the kidney issues and the bone loss. How did they work? Step 3. How did they work? I don't think they can ask us mechanism of action of any drug in step 2. I don't think so, but still very relevant for our step 3. We know that they are reverse transcriptase inhibitor. So what they do is that they are going to mimic nucleotide. You know that the action of reverse transcriptase is to be able to convert RNA to DNA. So these are the RNA. So it will now be forming complementary DNA strand like this. And the only way it can achieve it is by putting in nucleotide. No, not nucleoside, but nucleotide, and be elongating the chain. So what reverse transcriptase does is by putting nucleotide to the initial RNA structure and form a complementary DNA strand. Now, what this our drug is now going to do is that they are going to pretend as if they are nucleotide or nucleosides. Now, if they are nucleosides, that means that before they can act, we need to phosphorylate them. But if it's a nucleotide, it is already phosphorylated. You don't need to phosphorylate. That's a very good difference that we need to know. So what will now happen is that, so once you give a drug like abacavir, that one is a nucleoside. So we phosphorylate it to activate it. It will now be a nucleotide, and it will now be mimicking the other normal nucleotide. It will now deposit here. But one thing about this thing is that, you see, before we can elongate all these chains, right, we need to form what we call 3,5 phosphodiester linkage. So the 5 parties are the phosphate, the 3 parties are the OH group of the nucleotide. Now, the thing is, all these abacavir and zidovudine, blah, 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 that are coming, they lack this 3' OH group. They don't have it. So that means that by the time they come in and mistakenly reverse transcriptase deposit them, they will not be able to form the next 3,5 bond. So that chain is going to be truncated. So that's why they cause DNA chain termination. Very, very important stuff. Now, because of the fact that they also stop DNA chain elongation in the mitochondrion, they cause lactic acidosis. Because it's part of their side effect. I'm done with the mechanism of action now. So they also affect the activity of DNA polymerase in the mitochondria. And we know that mitochondria is a powerhouse where oxidative phosphorylation happens. So that means that oxidative phosphorylation is not going to be happening again. And there's going to be more of an anaerobic pathway into lactic acidosis. That's why majority of them, they cause lactic acidosis. So the way to quickly look at it is that they affect the mitochondrion, causing lactic acidosis. They affect the muscle and the nerves. The muscles and the nerve. Myopathy, peripheral neuropathy. And I'm emphasizing the common ones and important ones. And one of them also causes bone marrow suppression. So once we are seeing megaloblastic anemia, we are seeing leukopenia, quickly go and pick zidovudine. Zidovudine is a very, very, it destroys bone marrow. So, and of course, abacavir hypersensitivity in people with this HLO genotype. HLA-B57. So once you have HLA-B57 and you take Abacavir, it is a problem. So immediately they take it, they will develop rash, GI symptoms, and the likes. So we don't need to remember much. Just remember the lactic acidosis, the nerve, peripheral neuropathy, tingling sensation, the liver, the muscle problem, which is what? Myopathy. So nerve and muscle. Nerve and muscle. I don't know if you remember in physiology. We used to take that as a course. Nerve and muscle. So it destroys the muscle, causing myopathy. It destroys the what's it called? The nerves, causing peripheral neuropathy. Bone marrow, megaloblastic anemia. Abacavir hypersensitivity. Quick way to remember. Now, another thing that is common to them is lipoatrophy. So they can tell us that somebody was diagnosed with HIV and suddenly the person's head started becoming round. You are confused. What's happening? The head is becoming round. Okay. They said that the tummy is starting to swell up. The back is swollen. So the person is now becoming round, moon-faced. The person is now becoming skin. The leg is now like thin like this. Why the tummy is as big as this, and the neck, the side of the neck is getting swollen, but the head is thin. The extremities are thin, but the central area like the back and the tummy, they're enlarged. So that is the example of lipodystrophy that happens with people that you place on, antiretroviral drug. You want to ask, are you having Cushing's or you are on HIV medication? Lipoatrophy, very important stuff. So, moving on to the next one, which is what? The non-nucleotide reverse transcription inhibitor. Now, the example here is trend. There's nothing like the T. I just added the T to make it make sense. So the R is the repivirine, the E is the efavirenz, the N is the nevirapid, and the D is the delavirine. So you don't use D and efavirenz in people that are pregnant. So anybody pregnant, don't take E and D. You can't give them D and E. You don't want to do D and E for somebody that is pregnant. So you're gonna do D and E, you spoil the pregnancy. So you can't give delavirine and efavirenz in someone that's pregnant. They are contraindicated. E, which is efavirenz, is a very serious problem for CNS. They will be causing hallucinations, psychosis, vivid dreams. So somebody diagnosed with HIV, place on medication, start having vivid dreams, confusion. Best next step, discontinue efavirenz. Change to another thing. What does it need? How do they work? They don't need to be phosphorylated like the initial one. Don't forget the NRTIs. They don't need to be phosphorylated. You don't need to do anything. What these guys will just do is just to go and bind to another allosteric site on reverse transcriptase and they will silence it. That is all. That's all they do. Non-competitive inhibition. They're not competing with any nucleotide or nucleoside. They will just go straight and bind to reverse transcriptase and shut it off. That's all. So, but these guys are very problematic to the liver and they cause rash. That's all we need to know. So, generally, they affect the liver, they cause rash. So, drug reactions, Steven Johnson, TEN, these guys are the ones involved. And don't forget, you don't do D and E in people that are pregnant. Delavirdine and efavirenz, pregnant people, teratogenic. Efavirenz is very problematic to the brain. So confusion, anxiety, depression, CNS, psychosis, efavirenz. Vivid dreams, efavirenz. With that, we have summarized all the side effects. We have said everything that is there, everything. So moving on to the integrase. So once you are saying the word gravel, integrate, that's integrase. So what did they do is just from the name, they prevent integration of the viral what? They prevent integration of the viral RNA, into the host. They prevent integration of the viral DNA into the host DNA. So why do we say, I just want to test if we actually understand what we are talking about. Why did we say that it prevents integration of the viral DNA into the host cell DNA and not integration of the viral RNA? Anybody knows why? Anybody?
Because the reverse transcriptase enzyme would have worked
God
prior
bless
to
you.
integration.
Thank you, doctor. Reverse transcription will have done its own job. Reverse transcription will have done its own job. So it is already in DNA form. So once reverse transcription has done its own job, it will just pass it to integrase. Yeah, integrase, take. Integrase will now come, okay, thank you. Put it into the host. Host will now replicate. Then the last one will now come, which is what? The protease. Protease will now come and start cutting the protein to form new viron. So they inhibit at different phases. So don't forget that. At this point, reverse transcription has done its own job. So what is the problem with integrase inhibitor? You know, usually they will say something about metabolic syndrome and all those getting big, fat problems and the likes. They can have that, but usually integrase inhibitor is what you combine with your NRT. So you give 2 NRT with your integrase inhibitor for your treatment. That's what you normally do. Protease. So those are the azanavir, something indanavir stone, lopinavir, ritonavir, navir, And what they do is that they will prevent the cleaving. Don't forget, we have said it, cleaving. So if they cannot cleave, what will happen? They cannot form mature viral particles. And if they cannot form viral particles that are mature, they cannot cause infection anymore. Simple as that. Very simple as that. So what did they cause? They cause insulin resistance. So that means there's going to be hyperlipidemia and hyperglycemia. It's as simple as that. They can cause lipodystrophy too. So you just see fat distributing to the neck and the abdomen. And something peculiar to indanavir is that it can form crystal-induced nephropathy. So immediately, somebody comments on protease inhibitor and the person start having hematuria. Some people will be confused in that exam that, hematuria care. What's the connection now? What are these people setting? Indanavir is your answer. Just go and pick indanavir, you are smiling in the exam. So, what's it called? So there's something peculiar to this protease inhibitor, and that is ritonavir. Ritonavir can be used as a boosting agent. So ritonavir and saquinavir, they are like boosting agents. So meaning that they suppress cytochrome P450. So meaning that if you give ritonavir or saquinavir and it suppresses cytochrome P450, it will allow the other drug you are combining with it to act for a long time. So that's what we mean by boosting agents. So entry inhibitors, miraviroc, prevent docking by what? Inhibiting what's it called? CCR5 or CXCR4. And just like what I'm saying initially, I said before you start miraviroc, you want to what? Do assay for HIV tropism. We want to know, are you the type that you love CCR5 or the type that you love CCR? So that we'll know. Let us know. If you are the type that you like CCR5, okay, we can use miraviroc. If you are the type that you are binding to CCR4 majorly, miraviroc cannot work. It cannot work. So it inhibits binding of CCR of GP120 to what? CCR5. Very, very important stuff. Then enfuritide inhibits viral fusion by binding to GP41. It's as simple as that. Boosting agent, cobicistat, ritonavir, saquinavir. Those are the boosting agents. So once you give all these drugs, they will allow the drugs that you are combining with them to act for a long time. So that was that about the stuff that I feel that we need to know. And it's also important to know that the NNRTIs, the non-nucleoside, they are not active against HIV2. If you go and give somebody that has HIV type 2, you are giving the person efavirenz or nevirapine, we are just wasting time. It will not work. So, what is immune reconstitution inflammatory syndrome? Big name, very simple. What it means is that we reconstitute the immune system by giving someone that have HIV, somebody is newly diagnosed with HIV, and we start the person on heart immediately. We know that if you start the person on heart, the viral load is going to drop and the CD4 count is going to rise. So that means that you are giving strength to the immune system. So in a way, they can paradoxically reactivate latent infection. So in infection that are already latent, that has already calmed down, they can go and provoke them that, omo, agbára ti dé, there's power. You start looking for tuberculosis that is already gentle somewhere. Bam, bring it out. And the person will start having features of tuberculosis. That is immune reconstitution inflammatory syndrome. You know, so they can reactivate latent infections, you know, because of reconstitution of the immune system. So, and they can even allow some primary infection to also, you know, occur in a way. So that's why people with immune reconstitution syndrome, you have to be very careful. So what you want to do is that you want to make sure that somebody is newly diagnosed with HIV. You want to quickly go and screen for some latent infection to see if you might need to quickly start treatment for them before you commence the heart. So particularly Cryptococcus, tuberculous meningitis, and CMV retinitis. Those are the common ones. So some people also talk about shingles, tuberculosis, CMV, Cryptococcus, that you need to screen for them first before you start your heart. You know, so although, look at the statement here, although treatment of heart should begin immediately, you know, as soon as diagnosis, after HIV diagnosis, but it should be delayed to treat an opportunistic infection. You know, treat an opportunistic infection first, like Cryptococcus, like meningitis from tuberculosis, like CMV retinitis before you start. Because if you go and start HIV first, it's a problem. So what are the vaccinations that somebody that have HIV should get? So the way to just classify it is just look at it from 250 to 200 to 150, 200 to 50. We have already said it. Anytime we see less than 50 mentioned in our exam, it is mark. It has to be mark. It has to be mark. But the assignment is to look at it. Is this person on heart? Oh, this guy is on heart. He will not need mark. He will not need anything for mark. Some people will forget. Please don't forget. Some people will forget. So once you're on heart, you don't need any prophylaxis against mark. And we know that the rule for 100, if somebody is less than 100, it has to be toxo. If somebody is less than 200, it has to be what? Pneumocystic. Now, the one that we are now left with is now 250 and 150. So 250 is for coccidioidomycosis, while 150 is for histoplasmosis. Now, for the mark, I've said it. Once the person is on heart, don't give azithromycin again. For toxo, before you start it, you want to do IgG. If IgG is positive, it means that person has had a previous infection. So that previous infection can reactivate. So you need to give prophylaxis. You know, you need to give prophylaxis. So, then PCP, less than 200, you got, just don't do any screen, just go and give your prophylaxis. So if it's less than, and of course, if it's less than 200, your prophylaxis for your PCP2 will definitely be covering for toxo. So there's nothing to worry about. So if it's less than 250, then you have to obtain IgG for coccidioidomycosis. If it's positive, you can give fluconazole. Very important. Give fluconazole because the person had like previous infection or like latent, so it can kind of reactivate. Histoplasmosis, you don't need to do any screening. Just give like prophylactic itraconazole. You know, yeah, prophylactic itraconazole for histoplasmosis if it's less than 150. Yeah, less than 250 for coccidioidomycosis after your IgG is positive or IgM is positive. Mark, if it's not on heart, don't do it. If it's on heart, don't do anything. If it's not on heart, give your azithro. We have talked about 200, give your Septrin, and if it's less than 100 and IgG is positive, give Septrin 2 for toxo. So, but this is not all the vaccination. We also have to look at the other ones, which include pneumococcal. You can never forget pneumococcal. Influenza, you can't forget it. Meningococcal, you have to give them. COVID-19, hepatitis A and B. So these are the other ancillary vaccine that we must always give people with this HIV. So we want to avoid giving them live vaccine. Don't go and be giving them MMR. especially if their CD4 count is less than 200. So what are the indications for pre-exposure? So before you do something risky, you want to take the drug. So before I inject myself with drug, I have to take pre-exposure. Before I have sex with another man, I have to give myself the drug. Before I go and have sex with a sex worker, I have to give myself the drug. Before I have sex with someone that's HIV positive, I have to give myself the drug. So these are high risk behaviors in someone that is HIV negative. They are doing it intentionally. Having sex with a man, having sex with somebody with HIV, injecting drugs, all those things are considered high risk. So you need to give yourself pre-exposure. And what drug are you using? Tenofovir, alafenamide, emtricitabine combination only. For post-exposure, it's not intentional. Splash, they have like condomless sex with somebody that is high risk, maybe with a prostitute or a sexual worker. The person, mistakenly got in contact with, what's it called? Blood, breast milk, semen, vaginal fluid, playing with sex toys and all those things. High risk stuff, and you get contact with somebody that's having HIV, you quickly need to act. So just like we have a high risk sexual contact, you have condomless sex with somebody that is likely to have HIV, like men, another fellow man, or sex worker. Quickly go and take PEP. Get exposed to needle, needle, especially in the hospital. We have like a needle prick. You have to like quickly go and get screened and get a PEP, ideally. Get exposed to like body fluids that contains blood, or like semen, vagina, and all those things. We have to get it. So what do we give? We have to give them treatment as if we are treating them for HIV proper. So tenofovir, emtricitabine with integrase for 28 days. Then we screen them at the start. We screen them again after 6 weeks. Screen them again 3 months. So I think we are going to stop at HIV so that we can go and rest for the day. So what about precaution for perinatal transfer? Very, very high. You can't joke with this. So a woman that is pregnant, although testing for HIV is opt-out, you can say you don't want to do it, but ideally you should do it. But any woman that is pregnant should get ART. They should be on it. They should not say, I'm pregnant now, will it affect my baby? It will not affect the baby. They should take it. Except the person is using what drug? Anybody? E and D, or D and E. Unless the person taking Delavaren or Efavirenz, that's the only time that we can be worried of the baby. So give it like that, and we give the 2 NRTs and the integrase. That's for pregnant woman. Now, the next thing they like asking is about delivery. Once somebody that's HIV positive is pregnant, I don't want to know. The baby must take something. The baby must take zidovudin. Meaning, the baby cannot escape it. The baby will always take zidovudin. So let's keep this one. Now, what is now going to determine if the mother is going to get intrapartum zidovudin is going to be the viral load of the mother. If the mother is more than 1,000, don't ever try to do vaginal delivery. Immediately give intrapartum IV zidovudin and do cesarean section you can schedule it at 38 weeks, ideally. 38 weeks, cesarean section, intrapartum zidovudin for the mother. If it's less than 100, ideally, you can do vaginal delivery and not even give intrapartum zidovudin. Vagina, less than 100 is safe, so vagina is recommended. You might not give intrapartum zidovudin. If the mother is between 100 to 1,000, you can still do vaginal, but you should give IV zidovudin. So the only one that it is compulsory that you must use cesarean is when it's more than 1,000. 1,001, section. If it's between 100 to 1,000, vaginal delivery, but intrapartum zidovudine. If it's less than 100, safe to do vaginal delivery. You might not need to give, intrapartum zidovudine. You might give it, you might not give it. But for the baby, in as much as the mother is positive, so you just look at it. What's the viral count of the mother? The mother is more than 50. I have to give you New Zealand. The baby must take New Zealand. The first two are compulsory. Nevirapine, zidovudine, plus or minus lamivudine, New Zealand. If the mother is having copies more than 50. But if the mother is having less than 50, so you can just give NZ only for 4 to 6 weeks. Just give, you can give zidovudine alone. You can give zidovudine alone. So if the mother is having copies of 50 or less, give zidovudine alone to the baby for 4 to 6 weeks. If the mother is having more than 50 copies, you can give New Zealand, nevirapine, zidovudine, lamivudine, or nevirapine and zidovudine alone. So that is that. Let's see if you can solve one question. I will call it a day. There are a lot of questions here. Wow. Okay. So this is a 2.3 kg male born delivered to a woman at 39 weeks via cesarean section. The mother has HIV and she has received triple antiviral therapy during pregnancy. Viral load is 45 copies. 1 week prior to delivery. Delivery was uncomplicated. APGAR score is that physical examination of the newborn shows no abnormality. Which of following is the most appropriate next step in the management of this newborn?
Administer zidovudine.
Administer zidovudine. Straightforward. A 35-year-old man with HIV comes to the physician as a new patient. He feels well. The patient is a refugee who recently immigrated. Current medication is lamivudine, zidovudine, Indianavir. Family history signal for type 2 DM and hypertension in both parents. He has smoked 1 pack of cigarette daily for 10 years. He does not take alcohol or drugs. Vitals are within normal limits. Physical examination shows abnormality. CD4 count is 600 and HIV 1 viral load of 104. Which of following is the most likely adverse event of this patient's current antiretroviral therapy? Which is what? Which one is he taking? Anybody? Oh, my people.
Zidovudine, lamivudine, Indianavir.
Okay, so what's our answer according to what we have here?
Urolithiasis.
Urolithiasis.
Because of
Indianavir.
So which one should cause Stephen Johnson? Let me take it one by one. Which one should cause Stephen Johnson syndrome?
Nevirapine.
Nevirapine. Is it only nevirapine or collective?
It's collective.
Collective, the NNR.
Collective for which one?
Non-nucleoside reverse transcriptase.
Exactly. Non-nucleoside. Thank you. Which one for hepatic failure?
Non-nucleoside.
Non-nucleoside. If you remember, the algorithm I said was the liver and the skin. Hepatic, they destroy the liver and the skin. That's the non-nucleoside for you. Hypersensitivity, which one is that?
Abacavir.
I did not say pancreatitis though, but does anybody know pancreatitis? I did not say it.
It's inert device.
Protease.
That is the danosine. The danosine is the
the danosine.
CKD. Anybody knows that one? CKD. Which one is that one? We have said it. You have said it. So people should know it.
Tenofovir.
You don't know the view.
Which one was tenofovir? Which one? Which brand? TDHF. Disoproxy fumarate. So that's it. That's it. Yeah. You can see the way they said the options. So if you know what they are talking about, you already figure out what they are saying. So a 35-year-old woman comes to the employment services 30 months, blah, blah, blah. Let's just go straight to this stuff. So she works as a phlebotomist and reported that blood splashed to her right eye while she was drawing blood, and immediately she flushed the eye with water. The patient from who she drew blood was admitted for hemoptysis with and night sweat. He is an intravenous drug user and sexually active with male and female partner. So what's the prognosis of that person that the blood splashed to her eyes? What do we think of the prognosis? Is it high or low? Like, is it? Yeah.
It's high.
So it's already high. This person is having used every drug and is sleeping with man again. So the although the person is a woman, so well, that might not be. So the IV drop is more likely. So the phlebotomist has no history of serious illness and takes no meds. Immunization are up to date. Physical examination shows no abnormality. In addition to drawing our blood for viral serology, which of following is the most appropriate next step in management? What do we do for this patient?
A.
Post-exposure.
Post-exposure. It is as simple as that. Okay, let's look at this one. A 27-year-old man is brought to the emergency department by his partner because of 12-hour history of increased drowsiness. During the past week, he has also had fatigue and headaches. He has no history of serious illness and takes no meds. He appears lethargic and ill. Temperature is 38.7. Physical examination shows cervical, axillary, and inguinal lymphadenopathy. Neurologic examination shows no focal finding. Hemoglobin is 13.7. Leukocyte count is okay. CD4 count is 42. MRI of the head shows enlarged ventricles, bilateral gelatinous pseudocysts at the basal ganglia, and no mass lesion. A lumbar puncture is performed and CSF staining with mucicamine show organism with prominent red capsules. Screening and confirmatory tests for HIV are positive. Which of following is the most appropriate next step in the management? Anybody?
Antifungal and
Fungal therapy.
Nice.
So
nice.
you see,
I think I've heard another option. I think because don't let me say nice to something that is wrong. Go. Please, what is our answer? Is it A or B or C or D or E?
E.
I said it. I heard something different. So some people are saying A, some people are saying E.
It's E for echo.
E for echo.
So people that are saying E for echo, they are correct. But why did we choose E for echo?
Because of iris.
Exactly. We want to prevent iris. This guy is already having cryptococcal, infection. You can see mucicamine, cryptococcus infection. And again, this one they are describing, this bilateral gelatinous pseudocysts at the basal ganglia is very, very high. It's likely to be tuberculosis. I know that tuberculosis meningitis affect the basal ganglia. So, no, sorry, not tuberculosis, toxo. They say that tuberculosis affect the base of the brain. So this is likely to be like toxo or something. And of course, okay. And of course, from the mucicamine, we can say that clearly that this is, cryptococcus infection. So you have to treat that first before you go and give heart, because you don't want to do immune reconstitution, immune, response. So give antifungal therapy alone. That's what you are going to do. So, all right, that's fine. Very nice performance. All right. Do you have any question? Any question before we call it a day? Okay. I think we're almost moving. Thank you everyone for coming to today's discussion. We'll see you again tomorrow by God's grace. All right.
Thank you.